So, good morning to everyone. Welcome you all in today's first session that is on a very pertinent topic to our day-to-day practice, that is the gestational diabetes mellitus. And we have two very interesting lectures lined up in this session. The first lecture is by Dr. Alpesh Goyal, who is a well-known figure in this endocrine entity. And he is currently working as an associate professor at the Department of Endocrinology, AIIMS, Bhopal. And his area of interest is basically diabetes in pregnancy, type 1 DM, and adrenal disorders. And he has many awards to his credit. And now I invite Dr. Alpesh to speak on the early versus late GDM.
Thank you, sir. Good morning, everyone. Thank you, Team Mesicon, for giving me opportunity to speak on this topic, which is early versus late gestational diabetes. What is the difference? So gestational diabetes, as we know, is hyperglycemia with onset or recognition first time during pregnancy, which is not overt diabetes. But our understanding of this condition has evolved over the years, and we now understand that this is a very heterogeneous condition. And one aspect of this heterogeneity that has now been recognized is that you have two forms of hyperglycemia, one which is evident in early pregnancy, something which is called as early gestational diabetes, and something which becomes evident only as pregnancy progresses due to increase in insulin resistance of pregnancy, that is late gestational diabetes. So an early pregnancy screening is done mainly to identify overt diabetes in pregnancy, individuals who meet thresholds of diabetes in non-pregnant adults. But this screening may also identify someone who has hyperglycemia, which is intermediate between normoglycemia and overt diabetes, and that is something which is called as early gestational diabetes. There may be a subgroup of individuals who test normal in early pregnancy, but then during the course of middle or late pregnancy, they develop gestational diabetes, and that is something which is called as late gestational diabetes. And finally, there is a subgroup of women who remain normoglycemic during the entire course of their pregnancy. These are considered as normal or reference women for various studies. Now, just elaborating it with an example. So the first case, you have a 38-year-old female who at 8 weeks of POG, she clearly her glucose values on a 75-gram OGTT are suggestive of diabetes even in a non-pregnant individual. And this is a clear over diabetes in pregnancy, or you may also say that this is pre-existing diabetes which is being carried into the first trimester of pregnancy. A second case, a 12 weeks period of gestation lady who doesn't have normal glucose, but these are also not glucose suggestive of over diabetes, and this is something which can be called as early gestational diabetes as per the WHO criteria. On the third case, a 28-year-old female who is normal in her early pregnancy, but when you test her at 26 weeks, she had glucose levels that are elevated and suggestive of GDM, and this is classically a late GDM. So this is how we classify gestational diabetes in the current day as early and late gestational diabetes. Now coming on to the definition, for late gestational diabetes, which is diagnosed after 20 weeks, we know that IAD-PHG criteria, one-step 75-gram OGTT with glucose thresholds of 92, 180, and 153 are widely used, and these are recommended by most international bodies, although we do have a non-consensus here as well. And these thresholds are based on the HARPO study, which showed clear association between hyperglycemia and adverse pregnancy outcomes. And most international bodies recommend universal screening for late GDM at 24 to 28 weeks. On the other hand, for early GDM, we still don't have a clear consensus. We used WHO 2013 criteria, which also formed the basis for recruitment in the TOBOGM trial, which is very important in context of early GDM, and we'll discuss that. These thresholds are based on extrapolation of evidence from the HARPO study, which actually recruited women between 24 to 32 weeks and not in the early pregnancy, but just we have extrapolated that evidence. Some guidelines suggest universal, some suggest selective screening, but in the context of South Asian ethnicity where the prevalence of hyperglycemia in pregnancy is inherently high, we should probably be looking at universal screening for early pregnancy hyperglycemia in our ethnicity. The global prevalence of gestational diabetes overall, as per IAD-PHG criteria, is 14%, and of this, about 30 to 70% can be early GDM. This is now being recognized. The systematic review tells us that the prevalence may vary between 1 to 36%, and that is because the varying diagnostic criteria. from the individual studies, from the TOBOGM study, if we see the recruitment chart, we can see that about 22% of women in the TOBOGM study had early GDM. These were high-risk women. They were not universally screened. They selected women, and still they found a high prevalence of 22%. In the STRIDE India study, where they used only fasting plasma glucose, the prevalence was as high as 18% in the Indian part of the STRIDE India study. Coming on to pathophysiology, how is early gestational diabetes different from late gestational diabetes? For that to understand, we should understand the physiology of normal pregnancy. During the early part of pregnancy, insulin sensitivity and insulin secretion increases. And this is done by the body so as to ensure that mother accumulates adequate fuels, especially fats, to prepare her for pregnancy and for breastfeeding. But in the second part of the pregnancy, when the baby is developing very rapidly, the body wants insulin resistance to increase, and this is to ensure uninterrupted fuel supply to the fetus. That is why insulin resistance increases during second half of pregnancy. Now, what happens during both early and late gestational diabetes is that the insulin secretory response that we see to be augmented in early pregnancy is deficient. But in early gestational diabetes, there is early onset insulin resistance, which complicates the matter and leads to hyperglycemia diagnosed in early pregnancy. In late GDM, we understand that due to placental hormones, the insulin resistance starts rising later in the pregnancy, and that is why hyperglycemia also appears in the later part of the pregnancy. Now, we have understood that the glycemic trajectories in early gestational diabetes are not suggestive of persistent hyperglycemia. So not all women with early gestational diabetes have persistent hyperglycemia when retested at 24 to 28 weeks of gestation. Various studies show that the regression rates are as high as 30 to 55% amongst various studies, depending on whether you diagnose early GDM by fasting glucose criteria or by the OGTT criteria. So even in the TOBOGM study, which was published in NEGM, they found 34% regression rates, and the regression were higher in women who had lower glycemic values as compared to higher glycemic values as per the glycemic band they had decided, and we'll discuss that more. The mechanisms for regression, one is that OGTT is not a perfect test. OGTT is known to have poor reproducibility. There is differences in glucose metabolism, physiological decline in maternal fasting plasma glucose, behavioral alterations. Women is diagnosed, then there are chances that they may induce diet and physical activity regression to the mean. And finally, fetal steal phenomenon, which has now been challenged by the recent TOBOGM data, which shows that regressor women do not have high risk of neonatal hypoglycemia or large for gestational age babies. Coming on to pregnancy outcomes, how do pregnancy outcomes differ between early and late gestational diabetes? And it's been clearly shown that women with early gestational diabetes have a more severe form of hyperglycemia and have higher risk for adverse pregnancy outcomes. Now, this is data from New Delhi by Punos et al., and which shows that women with early gestational diabetes had increased risk of preterm birth, large for gestational age babies, NICU admission, and gestational hypertension compared to those with late gestational diabetes. And we have data from a systematic review and meta-analysis of by an Australian group of more than of 13 cohort studies, which clearly showed that women with early gestational diabetes had higher perinatal mortality, the risk being about 3.5-fold higher, higher risk of neonatal hypoglycemia, and also increased risk for insulin use. So that does tell us that it is a more severe condition with more increased risk for adverse pregnancy outcomes. But whether treatment for this condition is beneficial or not, so high quality RCT data were not available until recently when the TOBOGM study came up, and that showed us that it was a high quality RCT has come up, which showed whether treatment is beneficial in women with early gestational diabetes. So treatment for gestational diabetes diagnosed in early pregnancy, or TOBOGM study, was a multi-center randomized controlled trial which recruited women with early gestational diabetes diagnosed using WHO 2013 criteria from 17 hospitals in 4 countries: Australia, Austria, Sweden, and India. The major recruitment was from Australia. These 802 women were randomized to immediate treatment, where they were treated immediately with diet, lifestyle intervention, metformin or insulin. That is standard treatment, or they were deferred or no treatment depending on their OGTT values at 24 to 28 weeks. So in the control arm, if at 24 to 28 weeks they had hyperglycemia suggestive of GDM, they were treated, but they were not treated in the early pregnancy, while the intervention arm received treatment from the very beginning. So what was the primary outcome? The primary outcome was a composite of adverse neonatal outcomes, which included preterm birth, birth trauma, birth weight of more than 4.5 kg, respiratory distress, phototherapy, perinatal mortality and shoulder dystocia, and it was shown that there was improvement in terms of this composite adverse neonatal outcome. The risk for this composite neonatal outcome was lesser. You can see the difference is 5.6%, but the 95% CIs, if we see, are between 10.1 to 1.2%. So if we see the 95% CIs, the lower bound is touching 1.2. It's not touching the line of no difference, but it is just showing a very modest difference, and the difference was mainly derived by decrease in the incidence of neonatal respiratory distress. In terms of pregnancy-related hypertension and neonatal lean body mass, there were no differences that were seen. Interestingly, with the subgroup analysis that the TOBOGM study did, they divided the individuals into higher and lower glycemic range. So early GDM antenatal OGTT values, if you have higher glycemic range, which is HAPO or 2 or more, which means that if your glucose fasting is above 95, 1 hour is above 191, and 2 hours is above 162. Now these are the women who are in the higher glycemic range as compared to women with glucose levels between 92 to 94, 180 to 191, and 153 to 162. And it was shown that in this subgroup analysis, women with higher glycemic range antenatal OGTT values benefited more from the intervention as compared to those with lower glycemic values. And of course, if you have diagnosis of early GDM in very early pregnancy, that is before 14 weeks, the magnitude of benefit was higher. So that does tell us that it is not the whole group which is getting benefited, but the benefit is possibly higher in those who are having more severe form of hyperglycemia and those who are diagnosed very early in pregnancy, and if they are left untreated, then possibly there will be harm to such women. Now that is how the new cutoffs have been, the data from TOBOGM has been taken into account by Flemish guidelines and also by the ADIPS guidelines, and they have said that based on the new evidence, the cutoffs for early gestational diabetes may be revised to incorporate the higher cutoffs, that is using 95 or above, that is between 95 to 125 of fasting, 191 for 1 hour, and 162 for the 2 hours to diagnose early GDM, because possibly the intervention will be more beneficial in this subgroup of women. Now, apart from the subgroup analysis which showed a benefit of intervention in the higher risk individuals, there was also a signal for harm or small for gestational age babies, increase in incidence of small for gestational age babies, indicating overtreatment in women who were in lower glycemic band, that is individuals who had glucose values between 92 to 94 or 180 to 191 or 153 to 162. And as we can see, the relative risk for SGA babies is increased in the intervention arm if you were in the lower glycemic band. So that also tells us that the treatment has to be balanced. You cannot offer treatment to all women, and possibly over-treating women who had very milder form of hyperglycemia falling in the lower glycemic band may cause more harm to these ladies. So basically, the data from TOBOGM just tells us that there is some benefit of treatment of early GDM, but that benefit needs to be weighed in, especially individuals in higher glycemic band. Early gestational age at diagnosis are likely to benefit more, and if you offer unnecessary treatment to the individuals in the lower risk category, they may get harm. Now, some interesting secondary analysis also came up from the TOBOGM study. For this analysis, they only used the control group and the control group which was not treated. They didn't use intervention group which was treated. So you had 3 groups in this secondary analysis. Early GDM group which was maintained, that is they did not regress, they had persistent hyperglycemia. The regressor group which had regression from early GDM to normoglycemia, and then a control group which remained normoglycemic throughout the pregnancy. So they wanted to see whether the pregnancy outcomes in individuals who have a persistent phenotype of early GDM are different from those who have a regressor phenotype. And what did they found was that for the composite neonatal outcomes, the individuals in the regressor group had adverse pregnancy outcomes or neonatal outcomes which were comparable to a normoglycemic group. So that means that if you are testing with normoglycemia at 24 to 28 weeks, despite testing with early GDM in the early pregnancy, that is if you have a regressor phenotype, the pregnancy outcomes remain almost similar to the control group of the normoglycemic women. That means that these women also need to be avoided from overtreatment, and some biomarkers are needed to identify regressor phenotype early in the pregnancy. Another secondary analysis which kind of reinforced the data from the TOBOGM main trial was to look at whether the perinatal outcomes in early GDM versus late GDM group, taking early GDM control group. So early GDM less than 20 weeks not treated, diagnosed as GDM, treated from 24 to 28 weeks. So this is the control group which was not treated in early pregnancy but treated after having persistence of hyperglycemia at 24 to 28 weeks. The late GDM normoglycemia but GDM at 24 to 28 weeks again treated from 24 to 28 weeks, and the control group which was normoglycemic at 24 to 28 weeks. So if we see the first two groups, the only difference between these two groups is that the early GDM group had untreated hyperglycemia in the first half of pregnancy. Rest the two groups were similar, and what they wanted to see was whether non-treatment of early pregnancy hyperglycemia translates into adverse neonatal outcomes. And what they found was that the risk for composite pregnancy outcomes, composite adverse neonatal outcome, which was similar to the TOBOGM main trial, was increased in the early GDM group but not in the late GDM group compared to a control group. So which again tells us that it is that period of untreated hyperglycemia in the early pregnancy which has led to increased incidence of adverse neonatal outcomes, and non-treatment of and in the late GDM group, if you are treating them with whatever management after 24 to 28 weeks, the risk is similar to that of normoglycemia at 24 to 28 weeks. Now coming to data on postpartum dysglycemia, now there's some data on postpartum dysglycemia. We've seen that early GDM has more severe hyperglycemia. They're bound to cause more risk of adverse pregnancy outcomes, and the data also shows that they have higher risk for postpartum dysglycemia. And this is data from the TOBOGM study where 352 women agreed for postpartum OGTT at 6 to 12 weeks, and the overall prevalence of dysglycemia was found to be 26%. Now there was no control group that was reported in this study, and they found that postpartum dysglycemia obviously was higher if women had an early pregnancy OGTT in the high glucose band as compared to low glucose band, where the prevalence was varied from 32% to 18%. And the predictors for postpartum dysglycemia were higher 1 hour and 2 hour values, previous history of gestational diabetes, and greater gestational weight gain. And as part of the CHIP-F study, which is ongoing, we also looked at our own data, and we found that women who had early gestational diabetes have higher risk of postpartum diabetes as compared to those with late gestational diabetes. This is a median postpartum interval of 32 months, and we can see that postpartum diabetes rates are 22% in women with early GDM as compared to 12.6% in late GDM. And the hypothesis that has been put forward is that there is some persistence of beta cell dysfunction after GDM pregnancy, and that beta cell dysfunction persistence is higher in women with early GDM because they manifest a more severe form of hyperglycemia even during the pregnancy. So to summarize the current evidence, we can say that during early pregnancy, we can have women who have normoglycemia and they may remain normal during the course of their pregnancy. These are the women who are considered as the reference group. Then you have women who test as early GDM during less than 20 weeks period of gestation. They convert into normoglycemia, and this is a regressor phenotype, and they have outcomes which are similar to the reference women. So this is possibly false labeling of early GDM, and we have to be very careful in treating these women, and we need to identify these women through biomarkers which are needed in research studies. Then there is a group of women who have normoglycemia, but they convert into GDM at the later part of their pregnancy, and this is classically called as late GDM. Their neonatal composite outcomes were shown to be comparable to reference in the TOBOGM secondary analysis, but some outcomes they are increased risk, and we need to treat them carefully. And then there is a final group of women who have early GDM, and they maintain their GDM throughout the pregnancy, and this is the persistent phenotype and possibly true early gestational diabetes, which have higher risk of adverse outcomes. But we also need to individualize treatment given the data from the TOBOGM study, which shows that the benefit may be more marked in some group and there may be risk for harm in some subgroup of these individuals. To finally come to the conclusion of the topic that was given to me, the differences between early and late gestational diabetes. So classically diagnosed at less than 20 weeks, late GDM diagnosed at more than 20 weeks, typically at 24 to 28 weeks after normoglycemia and early pregnancy. Diagnostic criteria are variable. Most commonly WHO 2013 criteria have been used for early GDM, and for the late GDM it is most commonly IADPSG criteria. Pathophysiology is deficiency in augmentation of insulin secretory response. in early pregnancy, in both early and late GDM, accompanied by early onset insulin resistance in early GDM, and the usual late onset insulin resistance mediated by placental hormones in the late GDM. The risk for adverse pregnancy outcomes is higher in early GDM, as been shown in a systematic review and multiple cohort studies. Benefit of treatment in RCTs for early GDM is now available with the TOBOGM trial. With the late GDM, we already know that there are two landmark RCTs which showed benefit of treatment. These are ACOIS and MFMU trials. The natural history with early GDM, we have to be careful that 30 to 50% women may actually regress to normoglycemia, and they behave very similar to normoglycemic women. In terms of late GDM, we have seen that women with late GDM have neonatal outcomes similar to those with normoglycemia at 24 to 28 weeks from the TOBOGM analysis, but these were treated late GDM women. And the risk for postpartum dysglycemia is higher in women with early GDM as compared to late GDM. Thank you so much for your kind attention, and I would like to acknowledge Dr. Yashdeep Gupta, who is my teacher and mentor. Thank you.
Thank you, Dr. Thank you, Dr. Alpesh, for an excellent presentation. We'll take the questions after that. Yeah, I will take the questions after the second session. Now, for the next talk, I would like to invite Dr. Prakash Keshwani, who is from NIMS Medical College, Jaipur. He is a senior professor in medicine and endocrinology and teaching faculty for medicine and endocrinology, president of Endocrine Society of India, Rajasthan affiliate, member faculty selection board, Institute of Medical Sciences, BHU, chairman research committee, RSSDA, Rajasthan chapter, scientific chairman, Jaipur API chapter, and 44 publications in peer-reviewed journals, organizing chairman, ASHICON 2022, Jaipur.
Thank you, Chairman Sir, for your kind words. Respected chairpersons, senior colleagues, and dear friends, a very good morning to all of you. At the outset, I shall like to thank the organizers for giving me this opportunity to be with you all in this morning. Here we will be discussing the role of metformin in diabetes in pregnancy. Insulin is traditionally being used for the management of the gestational diabetes for long, considering it is a physiological treatment, but metformin at the same time is being used randomly for last around a couple of decades. These are the latest data from the IDF 2025 as well as the ICMR 2023 says that India has a big number of diabetes. We will not go in the prevalence, but 1 out of the 6 pregnancies are affected by the high glucose levels, and this accounts for the GDM also. And GDM accounts for around 10% of the pregnancies in the rural areas and 12% in the urban areas. To classify diabetes in pregnancy can be pre-existing, type 1, type 2 or other types, or the typical GDM, which can again be the pre-existing diagnosed for the first time during pregnancy, or the true GDM. We all know that maternal and placental factors are implicated in the pathophysiology of gestational insulin resistance, and that is the reason for development of the gestational diabetes. And metformin acting through multifaceted mechanisms in the cells causes AMPK activation, leads to a decreased gluconeogenesis, improves glucose transport in the muscles, and thus reduces the insulin resistance and typically controls the blood sugar levels, and thus also affects the pathophysiological mechanism of the GDM, which is mainly by the insulin resistance. The question is, why metformin? The other one says, why not metformin? The concerns are there. Metformin is shown to significantly cross the placenta with fetal concentration in the range of half of the maternal concentrations. And however, but it does not have been found to stimulate insulin resistance secretion or cause hypoglycemia. And it has been used throughout the world for last couple of decades. And metformin insulin enhances the insulin action, stimulating the glucose uptake in the liver and in the periphery, and also suppresses hepatic gluconeogenesis, thus helps in managing GDM. Why metformin? Metformin is useful in treating insulin resistance in PCOS also, and most important is an oral therapy and welcomed by all the patients. It has been used in several trials, and not even a single trial has reported as major congenital malformation with the treatment for the metformin. Whether the patients for the mothers for the diabetics or the non-diabetics, no congenital malformations have been reported with the treatment with the metformin. Several studies show that metformin use is being practiced for last couple of decades. Here are the studies for last 30 to 40 years from different part of the world, and they have been using metformin without any major side effects. The question is whether metformin is safe for the pregnancy. 126 neonates born to the 109 mothers who were suffering from the PCOD, and they continued taking metformin throughout the pregnancy. And these children were followed for 18 months at the time of the birth and up to the 18 months of the age. There was no difference in the height, weight and motor or social growth over this period of 18 months. This suggests that metformin exposure in the antenatal period is quite safe, do not causes any gross abnormality in these patients. What happens in diabetic patients? Yes, the patients, the GDM mothers who were treated with the insulin or the metformin and the diet, and metformin group was found to have favorable impact on the rates of macrosomia and the children were the small for the gestational age. Is metformin therapy as safe as insulin in the pregnancy? An important trial, metformin versus insulin for the treatment of gestational diabetes, MIG trial. Here 750 mothers were included, and they were categorized, randomized into the two groups. One group was treated with the metformin and other was treated with the insulin. Neonatal complications did not differ, whether it was the respiratory distress, sepsis, need of phototherapy, birth trauma or the ABGAR score. So this was found to be safe as far as the neonatal outcome was concerned. While looking for the neonatal outcomes, the birth of the baby, gestational age at the birth, head circumference, head to heel, crown to heel length, or the crown to the head, all were found to be same in both the groups, and there were not any harmful effect on the fetal growth or the fetal development in the patients who were taking metformin. While looking for the maternal group, there were no metabolic, there were no other side effects, but rather maternal hypertension, including preeclampsia, was much less common among the patients who were being treated with the metformin as compared to the insulin. And the women in the metformin group had lesser weight gain between the time of reporting and 36 weeks of pregnancy. So women of the GDM treated with the metformin has later weight gain as compared to the women who were treated with the insulin. And what happens to these children later on in the MIG trial? The offspring follow-up, MIG-TOFU. After 2 years of follow-up, these children did not show any delay in the development, whether motor or social, but fat component was found to be higher in these patients after 2 years as well as after 7 to 9 years. So abdominal fat deposition was slightly more in these patients. Otherwise, development and no congenital malformations and physical and mental growth was found to be similar in these patients. So MIG trial suggests that metformin is an effective and safe treatment option for women with the GDM. Another important trial, a case control study, pregnancy outcome was seen in women with the gestational diabetes, and women with the GDM treated with metformin had less weight gain and improved neonatal outcomes. Another placebo-controlled trial, multicentral trial, metformin in women with the type 2 diabetes in pregnancy were studied, and several maternal glycemic and neonatal benefits were observed in the metformin group. Lesser maternal weight gain and insulin doses and improved glycemic control were observed. Can metformin be started in the early diabetics? Group was treated with the metformin or the placebo, and it was observed that these patients had slightly better glycemic control who were treated with the metformin as compared to the placebo, and this metformin group has lesser chances of supplemental insulin therapy later on. So thus it's clear that early metformin can help in managing these patients for better glycemic control and lesser need of the insulin in the future. these patients who were born to the mother who were treated with the metformin were followed up, and it was found up to the adolescence. There was no delay in the development of these patients, including milestone, IQ, and other neurological development. This is the meta-analysis of 21 RCTs, which concluded that metformin may have potential benefits for pregnant women and newborns in terms of maternal and fetal outcomes. This again a network meta-analysis. Different kind of the glucose lowering measures were used: metformin, insulin, glyburide, diet and exercise, and metformin and insulin. We can see in the A category, the Sukra ranking was best for the metformin, whether it was the neonatal hypoglycemia, macrosomia, low for the gestational age, preterm birth, or the requirement of the cesarean, and gestational hypertension or preeclampsia. So metformin was found to be better as compared to even the insulin for these all parameters. To summarize, we can say that metformin is quite a good drug. It reduces insulin resistance. It can be given orally. It is quite efficacious, efficient, and glycemic control is comparable to insulin and or glyburide. Socially better acceptable, less cost, less monitoring. Maternal outcomes are always good because it causes low weight gain during the pregnancy, and as well as the hypoglycemia is also less in these patients. Shorter fetal outcomes equally good, but there is a risk of having excess weight in the follow-up in the childhood or adolescence with the in the children who were treated with the metformin. So what do the guidelines suggest? Guidelines typically for years recommend that insulin is the first drug of choice, except that of this maternal fetal medicine guidelines. The Society for Maternal Fetal Medicine, which say that metformin is also the first line drug, and the NICE guidelines, we say that metformin is the first line drug, but rest of the other guidelines suggest that insulin is still the first choice, and if those patients who are not able to take insulin or has some problem in taking insulin, metformin can be given. ADA also recommend for this, can be used as a second line. This was about the benefits of the metformin. What is about the cons of the metformin therapy in GDM? Various neurological disorders are associated with maternal B12 and vitamin and folic acid deficiency, such as spina bifida, anencephaly, and other brain abnormalities. We know that metformin therapy is associated with the B12 deficiency, and we have to take care for this also. The patients the children born to the mothers who were taking metformin, there was they had a greater BMI in the adolescence, and that can have a cardiometabolic risk. This again we have to keep in our mind. Again, these patients have excess fat deposition after 9 months of the age, and in the adolescence they have increased fat in the mesenteric area, and that can again become, and the male offspring also showed impaired glucose tolerance and even fasting higher glucose who were the children born to the mothers who were taking metformin. So this mild complications or mild disadvantage in the children can be seen later on. To summarize, metformin may fail to achieve adequate control in some patients. Because of the increased renal clearance, there is a need for higher doses in some of the patients, and significant placental transfer also occurs with the metformin. Failure rate is quite common. 14 to 46% of the patients on metformin may require insulin supplementation. Socially, it is recommended by most of the guidelines that insulin is the first line drug. Maternal outcome, slightly lower gestational age. So these female have gestational age slightly lower as compared to the insulin. Otherwise, small gestational weight gain and other benefits are there. Short-term fetal outcomes, there is an increased risk of preterm birth. So these children are born slightly early, and of course the disadvantage we were discussing later on, these children may have insulin resistance. This review suggests that there are certain advantages for the maternal outcomes. There is a lower gestational weight gain, lower risk of any hypertensive disease of pregnancy, including preeclampsia, high risk of gastrointestinal side effects, no difference in the risk of preterm birth, no difference in the risk of delivery by cesarean sections, and lower risk of the maternal hypoglycemia. In neonatal, we can see there are less chances of macrosomia, and there's no difference in the neonatal abdominal circumference or other abnormalities. In the children outcome up to the age 2, they are normal. 2 and afterwards, they have slightly more fat, and that can lead to the insulin resistance in these patients. So we can see, as far as maternal weight gain is concerned, gestational age at the delivery is concerned, infant birth weight is concerned, that favors metformin therapy, while maternal risk, as far as preterm birth is concerned, insulin is slightly better. Pregnancy-induced hypertension, preeclampsia, and infant factors like that, large for gestational age, small for gestational age, and infant hypoglycemia, that favors the metformin therapy. This meta-analysis again concludes that metformin is comparable with the insulin in glycemic control and neonatal outcomes. It might be more suitable for women with mild GDM. This meta-analysis also provides some significant benefits and risks of the use of metformin in GDM and helps to inform further development of management guidelines. So metformin is safe in early pregnancy with no risk for congenital malformations. If used throughout pregnancy, it is likely to lead to reduced maternal weight gain and reduced insulin dose in women with type 2 diabetes. In infants, metformin reduces hypoglycemia and macrosomia, but may increase the rate of infant born small for gestational age. There is some evidence of an increased risk of obesity and altered fat distribution in offsprings later on. Metformin appears well tolerated in pregnancy and is more acceptable to women than insulin therapy. Due to increasing rate of maternal obesity, GDM, and type 2 diabetes, metformin use in pregnancy is increasing. So what we have learned by all these studies, that metformin presents itself as a potentially effective oral substitute to insulin in treatment of GDM, demonstrating its capacity to regulate blood sugar levels, prevent weight gain during pregnancy, and decrease the occurrence of the neonatal hypoglycemia. In light of these results, metformin is potentially effective method for enhancing the safety and general health of pregnant women with GDM, thereby presenting a useful avenue for improving neonatal and maternal outcomes. The last, I will like to thank you all for the patient listening.
Thank you, Dr. Keswani, for your wonderful presentation. Kindly join us for the question answer session. So the session is now open for question answers and discussion.
Dr. Alpesh, thank you for the lucid presentation, Dr. Prakash sir. My question to Alpesh is then, because you have shown the differences, but for this audience, what is the message that you want to convey? What is the cutoff that we should use in the early pregnancy to diagnose or to treat? And if treatment has to be thought of, can we think of metformin or it's only insulin? As per the guidelines and as per the things.
So there are two parts to your question. What diagnostic thresholds do we use?
To treat in early gestational diabetes.
So see, the evidence, there is no concrete evidence to suggest that the diagnostic thresholds, the WHO 2013 criteria, they are not based on any outcomes which were derived from women who were recruited in early pregnancy. But now that we have an RCT, the TOBOGM study, which included women diagnosed with WHO 2013 criteria, we can use that in our clinical practice. But that also shows that the benefit is quite modest, and that is not in terms of change in LGA babies, macrosomia, or in neonatal hypoglycemia, something that we attribute more to hyperglycemia. It's mainly driven by neonatal respiratory distress, and the outcome benefit is very modest. The more important part is that the women who have more severe form of hyperglycemia, they are going to benefit more. So possibly those are the kind of women, you can label them as high-risk women. One, women with higher glycemic bend, those with glucose values of more than 95, 191 or 162, or those who have been diagnosed in very early pregnancy, less than 14 weeks. So fetal insulin secretion starts as early as 14 weeks. So if you are leaving hyperglycemia untreated for a longer duration, that is going to be more harmful. So those are the two groups of women where we should be more careful. That management doesn't differ. That's why I didn't discuss that in more detail. The TOBOGM study also used the same management protocol as you would use for standard GDM. So the management would include dietary and lifestyle intervention, structured dietitian review, review after 2 weeks with the blood glucose log, the targets that have been used are also similar. The targets that we have used from the ECOIS and MGMU studies, the targets will remain same: fasting glucose of less than 95 to 100, 2-hour glucose of less than 120 to 126, and a 1-hour glucose of less than 140. Now the question about what to start with, whether to give metformin or insulin, again the TOBOGM trial was open to the study investigators to use either of them as per their standard practice. With regards to metformin use, there are certain caveats that we should consider when using in early pregnancy. One, that this is also the time when SCG levels are peaking, and women may have nausea and vomiting. So that may be exacerbated, and they may not tolerate it very well. Other aspect is that even in the MIG trial, when the treatment was started after 20 weeks, you saw that failure rates for metformin was as high as 46 to 50%. When you are starting treatment in early pregnancy, knowing that this condition has more severe form of hyperglycemia, more severe form of insulin resistance, your failure rates are going to be higher. So you are invariably, you will like to transition the patient to insulin therapy as an add-on therapy or as a substitute. Other third thing is that with the late GDM evidence that Shara has also shown, the exposure has been during later part of pregnancy. If you start metformin in early pregnancy, your exposure is likely to be longer. So the long-term outcomes we don't know. So exposure will be longer, and it will also be at a time when fetal organogenesis is occurring, and we know that metformin does cross placenta. So the answer to this question is not concrete at this point in time, but we can treat early GDM very similar to standard GDM as of now.
Thank you. Prakash sir, just continuing the question, sir. So you said that metformin can be used in pregnancy as such, and the guidelines are saying, and we all know that when we talk about in early gestational diabetes, when we diagnose and we offer the treatment that insulin will be better, but still metformin, if the patient consists, then we do write about metformin. So what do you say, because guidelines also divided on that. So what do you...
Guidelines still majority of them suggest for the insulin as a first line drug. But a number of studies are there which also confirm that there is no teratogenicity. If patients tolerate, as the Dr. Alpesh told, there are no GI side effects, we can put them on metformin. Higher is the glucose, more are the chances of supplemental insulin later on. Longer duration of GDM, again more are the chances for insulin. So balancing all these things, we can take particularly obese mothers and who have developed obese mother with the diabetes or GTM can be preferably put on the metformin because of the lesser weight gain during pregnancy. Of course, we have to keep watch for the supplemental insulin if not control with this. As such, there are no other side effects.
One more question, Alpesh, to you. That you said regressors. So we have diagnosed early gestational diabetes as per the WHO criteria, and we have put the patient on dietary management. So regressor means only person who were on dietary management. Again, we repeat the GTD. Do you suggest that we should repeat the GTD once we have diagnosed GTD in GDM as? This is very surprised to me that we'll tell regressor the word.
So whatever data for regressors is from, one is from the pre-TOBOGM data, when early GDM was not a very established condition. So there was no clear consensus whether to treat these women. You have diagnosed these women, then you repeated OGTT. For example, the study by Zhu et al. From China. That was first study which said that if you diagnose gestational diabetes in early pregnancy based on a fasting plasma glucose threshold of 92 to 125, which was proposed at that time by IADPSG and was subsequently withdrawn, they showed that this is not a very precise estimate, because these women may actually show regression to normoglycemia, and depending on the level of hyperglycemia, they showed that if glucose is more than 110, they are more likely to persist. But if it is between 92 to 99, as high as 65% women with regress. Even with the TOBOGM trial, the data that I showed of 34%, that was in the control group. So the control group did not receive any treatment, and they were retested. So I think you've raised a very valid point. What I do in my practice is that if women with early gestational diabetes, I'm not putting them on treatment, just on diet and lifestyle management, especially the low risk group, I will repeat an OGTT at 24 to 20 weeks.
Thank
you. No, up to 20 weeks period, when should I test blood glucose and how many times to level as early GDM?
The first part of your question was what weeks of gestation?
At what week? It is 20 weeks, less than 20 weeks. So should I go for in the 4 week, 6
Okay.
weeks, 8 weeks, 12 weeks, 20 weeks, something like that? Or there is a special time when we shall go for early GDM test?
Sir, the simple answer to this question is at the first antenatal visit. Whenever you have the first encounter with the pregnant women, you should go for hyperglycemia testing, and that could be in various combinations. You could go for a fasting plasma glucose, or you could go for a complete OGTT. Given the high risk phenotype that our women have, we generally prefer a complete OGTT at the first encounter.
Suppose the patient has came to me at the 8th week of pregnancy, I did it. Should I go for again testing it in the 20th week?
No, sir, that will not be needed as per the current current understanding. If 8 weeks testing is normal, you should tell the women that she continues to manage her pregnancy normally, follow antenatal treatment, a balanced diet, and come back for a repeat OGTT after 24 weeks, between 24 to 28 weeks.
Okay.
Will she not develop, is it, there is no
Gynecologists
chance of her
usually
developing
supplement
early
nowadays.
diabetes?
Gynecologists usually supplement.
No, it was actually a continuation of that question. So I'll ask. Say we did the tests at 8 weeks and it was normal. Is there no chance that she can develop early diabetes mellitus, say at 10, 12 weeks? Don't we need to do another testing?
Ma'am, we also need to be pragmatic. It's not, it's not easy to get OGTT done in pregnant women. It also brings in, resource constraints, long waiting times. So what has been seen is that if you, why you want to test for early pregnancy hyperglycemia is, one, you want to rule out any undiagnosed diabetes,
Right.
which unfortunately is increasing in our country. So that is one thing. And you also want to rule out any early pre-pregnancy hyperglycemia, say pre-diabetes that women is carrying. So if 8 weeks OGTT is fairly normal, then you may not want to repeat it because you just wanted to rule out any pre-pregnancy hyperglycemia. And next, after 20 weeks, you would expect, the placental hormones to increase, and that is why you will repeat it after 20 weeks.
But OGTT is a must. Like it is a little difficult for the patient also to undergo that test. Fasting glucose alone shouldn't be a criteria.
With all the limitations that OGTT has, as of now, that is the standard of care.
Thank you so much. I'm so sorry.
That's okay. Okay, Dr. Prakash, just wondering, do you have any CGMS data comparing metformin with insulin? I can just recall one about a year ago in a low-impact journal, about 22 patients on each arm, which showed that the time in range, 1 hour, 2 hour, was similar to both of them. So do you have any knowledge about CGM
I
data?
do not have any such data, and not any big publication I could come across.
Okay, and
But
question.
CGM nowadays is being recommended for the GDM also for better glycemic.
Yeah, that's what surprised me, that it is recommended, but we don't have any
Yes,
data
now it is
comparing
being
this.
quite
This will be the
recommended
best
quite strongly.
comparison, because you've got 1 hour, 2 hour, half an hour, whatever
For
postprandial
more strict
data.
maintain- More strict control.
And question to both of you, do you use the DIPSY criteria at all? Because I don't.
Quite.
I use fasting and PP with OGTT. But
That is
with
the-
just an OGTT 2 hours, do you use that in practice? Well,
That
I
is
think
the
we might be
usually we
missing
have
the
gone
fasting
through,
hyperglycemia.
And we usually recommend for it. But dipstick otherwise seems to be quite practical. Whenever a patient comes to you for the first antenatal visit, give her glucose and measure after 1 hour. If more than 140, diagnose it as a GDM. So it's quite practical, and they recommend it because they think that India is a country where we cannot ask the patient to come repeatedly and because of the poor affordability of the majority of the patients.
I agree it's pragmatic, but I think we also have higher insulin resistance. We might be missing the fasting hyperglycemia, particularly in the initial bit. So I use both fasting and PP. And second, and the last question, is there nobody else to ask? When comparing metformin with insulin, do you have any India-specific data?
Yes, I also showed you the one study, and that was from India, and couple of studies are there. and majority of them are not very big studies.
Hmm.
3 studies I have come across, and yes, there are.
Okay. Thank you. Thank you.
So my question is, over diabetes below 20 weeks, why I should call it GDM? It can be pre-existing diabetes. And I like to perform OGTT at the very first antenatal checkup. It may be 3 weeks, 4 weeks, 7 weeks, anything, and she is pre-existing diabetes. She is having pre-existing diabetes and should be treated like other diabetic patient.
Sir, your question is a women who is not known to have hyperglycemia during pre-pregnancy period. For the first time you test her and you get over diabetes, that will be through an OGTT, sir. OGTT.
For those specific candidates, HbA1c will be a good choice. Patient is pregnant for the 4 months and you find HbA1c of 9. It is clear cut she is pregnant at diabetes for last three months. But as the Dr. Alpesh was saying, there is no other way to find it out, and any patient who is diagnosed diabetic for the first time during pregnancy is called as GDM, whether it may be pre-existing or freshly developed diabetes.
Alpesh, just a brief question. During your review, did you find any data where people have looked at, a GDM who actually had normoglycemia after testing an OGTT in the first or early gestation, and then treated them or did not treat them? Why I'm asking you this is you've said that, if those who had early GDM along with late GDM had worse outcomes compared to those who had late GDM, but they were all treated. So do you have any study, may not be existing literature, just or even from a retrospective systematic analysis, have people commented on a situation where there are two classes of GDMs, one who might have had early GDM, the other who may not have had. So what is the difference between these two? Has there been a study comparing this?
Sir, if I understand your question correctly, those who have early and maintained GDM versus those who only have late GDM.
Yes. But normally if somebody comes to GDM, we treat.
Yes, sir.
We offer treatment. We can't withhold treatment.
Yes, sir.
Isn't it? So that is the issue. So are we over-treating late GDMs in the sense that those who did not have early GDM may not benefit?
Yes, sir. So that's a very pertinent question, sir. Now, earlier we didn't know that GDM, which we are diagnosing at 24 to 28 weeks, whether it was early pregnancy hyperglycemia that was being carried on, or they were just normoglycemic in early pregnancy and then they were developing. So that is what the secondary analysis from the TOBOGM looked at, sir.
No, but these were all treated, no?
No, sir. That's what I told, sir. They only included the control group. Even in the RCT, they had two groups. The intervention group, which received immediate treatment. The control group did not receive immediate treatment. So the control group, which was 400 women, early GDM, they did not receive immediate treatment. Then they were diagnosed with GDM at 24 to 28 weeks. They were treated. Then there is another group who were normoglycemic at less than 20 weeks. Then they receive a diagnosis of late GDM. They receive treatment. So both groups are very similar. They are receiving treatment from the late pregnancy.
And they differed in outcomes.
Yes, they differed in outcomes, sir. In terms of composite neonatal outcomes, all the preterm birth, whatever the TOBOGM study included the primary outcome, they were different. The late GDM treated group was similar to the control group in terms of composite outcome, but they had some increased risk for respiratory distress, phototherapy, and NICU admissions. So that just tells us that we cannot leave that early pregnancy hyperglycemia untreated, especially in the high-risk women.
What about those who develop GDM late? Are we over-treating them? That question is
yes,
answered.
Sir, so that question remains whether if you are testing normoglycemia in early pregnancy, whether you should be more aggressive in treating women who develop hyperglycemia in late pregnancy, because ultimately it may boil down to treatment in the early part of pregnancy. Yes.
Yeah, is there any role of HbA1c in diagnosing early GDM?
So, sir, in extension of what was being discussed, the role for HbA1c in pregnancy is mainly at less than 15 weeks. And if you get an HbA1c of more than 6.5%, more than equal to, you can straight away diagnose women to have over diabetes in pregnancy. Especially if you have over diabetes in first trimester, it is very likely that it is a pre-existing diabetes. Now, with regards to role of HbA1c in early pregnancy hyperglycemia and adverse outcomes, there are data from various studies. For example, a study from New Zealand showed that HbA1c of more than 5.9 is associated with increased risk of adverse outcomes. There are two good studies from India, one by, again, Dr. Punnos et al., which showed that HbA1c of more than or equal to 5.5% in early pregnancy predicts preterm birth. And then there is analysis of Stride India study, which Dr. Mohan's group was part of, which again showed that HbA1c cutoff of 5.4% or more predicted incident GDM at 24 to 28 weeks. So possibly we can keep that number in mind. There are no clear consensus that HbA1c can be used for diagnosis of hyperglycemia in pregnancy or whatever, but if the levels are more than 5.4 or 5.5, that's for the research studies to look at whether we can, that can be predictive of adverse pregnancy outcomes or incident GDM.
Thank you, sir. Sir, I have one last question. So what is your opinion on TYG index in GDM? Actually, there are a number of studies which are being now being done, not in GDM, but in otherwise. Actually, there is no such clear cutoffs for TYG index and its correlations with OGTT. So is there any opinion about the TYG index in GDM?
So I don't have any personal experience. It's basically a marker of insulin resistance. So you expect TYG index to be elevated during later part of pregnancy in women who have conventional standard GDM and to get elevated in the early part of pregnancy, but I am not aware of any cutoffs.
How safe is metformin during lactation, sir?
Again, some concentration can be found in the milk, but again that have been found to be not detrimental or harmful. No such data is there that metformin during lactation can be harmful to this patient.
Thank you both the speakers, and I would like to end the one question. Okay.
The OGTT values, 95, more than 192 and 162 you said. If any one value is greater and the others are normal, then do we take it as early GDM?
So the clear consensus is that if any one value is elevated, you can diagnose.
See, you said that gestational period later, insulin resistance rises because of providing the fetus with sugar. Will this, like if we treat it overtly, all the GTTs below and one is only above, then will the outcome of the fetus be hampered?
That's true, ma'am. If you overtreat any pregnancy with hyperglycemia, you may end up giving complications such as small for gestational age, because
that you said. But what are the real criteria? Like if insulin resistance is helpful for the fetus, and still we use the same levels.
Yeah, that's helpful in a physiological pattern, but when it becomes pathological,
crosses the levels, then it's pathophysiological.
And especially with somebody having pre-existing beta cell dysfunction.
Yes, I get it.
So all are to be treated, not necessarily with the drugs. Firstly, diet and exercise, and then only the drugs are to be. So there is lesser chances of overtreatment.
Sorry, due to time constraint, we are not able to take any more questions. Thank you, sir, for the excellent deliberations about the topic GDM. For the next topic will be in diabetes in young. And for this session, I would like to call Dr. Shubodh Bansal, sir, and Dr. Rajashri Mukhopadhyay, sir, on the dais.
Good morning, everybody. Thanks for organizers for calling us here. I think we have this session for diabetes in young, And I think monogenic diabetes or genetics have certainly changed the practice of endocrinology. It will be changing more and more as the time comes. In our days, we did not read much about the genetics. Now things have changed. And we have 2 topics or 3 topics are there which will be discussed today. And without wasting time, I invite Dr. Ish Bhatia, who will be talking about the screening for monogenic diabetes in Indian patients with type 1 diabetes, because there are many patients type 1 who remains on insulin for long time, and they may be certainly diagnosed as monogenic and be treated in a better way. Okay, Ish is MD Medicine, and he's Senior Consultant and Head of Diabetes and Endocrine at Apollo Medics. I think you have left SGPGI. That's okay. And his total publication 102, chapters in book 17, is a research grant extramural total 8, research interest in type 1 diabetes, fibrocalcium pancreatic diabetes, MODI, additions, autoimmune polyendocrinopathy. Over to you, Dr. East, please. Thank you.
Thank you, sir, for that introduction. And I will be speaking on screening for monogenic diabetes in Indian children who are actually initially diagnosed as having type 1 diabetes. And before I start, I want to thank the scientific committee for allowing me to give this talk, and to the organizers for holding a wonderful ESICON. I'll talk about these 3 things in brief. Idiopathic type 1 diabetes. Is that better? Okay. So I will talk about these 3 topics: idiopathic type 1 diabetes and monogenic diabetes in Indian patients with type 1 diabetes, and in short about Wolffram syndrome. Everybody knows the etiological classification of diabetes very well, so I'll just go through it quickly. You have patients with type 1 diabetes in which there is a beta cell destruction and severe insulinopenia. In most instances, this is immune modulated, and you have markers circulating in the blood in the form of antibodies, and in a smaller proportion, it is idiopathic. Then you have type 2 diabetes, which is not so common before the age of 16, 14 years of age, before puberty, and then other specific types. And some of these can be misdiagnosed as having type 1 diabetes, and these include some forms of MODI. And of course, neonatal diabetes is diagnosed less than 6 months of age. You should rule out in India exocrine pancreatic deficiency, because sometimes the pain is not very severe and it is missed. And then you have other genetic syndromes which are associated with diabetes, like Wolffram syndrome, mitochondrial diabetes, AAA syndrome, etc. And they actually can have, in addition to the other syndromic features, they can have actually quite severe diabetes. So Islet antibody negative type 1 diabetes, idiopathic or type 1B, you can call it what you want. It forms 1 to 5% of type 1 diabetes in European children, but a higher proportion in other ethnic groups, for example, in Africans, Chinese, and Indians also. And there are many variants of islet cell antibody idiopathic diabetes, for example, something which has recently been described from sub-Saharan Africa. And then you have a fulminant type 1 diabetes, which is described in Japanese. And you have a ketosis-prone flatbush diabetes, which is described commonly in Hispanics and blacks, in which actually the patients are obese and they present with ketoacidosis and very high blood glucose. And then they get controlled, but they again can have relapses. And you need to, like I already mentioned, rule out pancreatic diabetes, monogenic diabetes. And you also need to make sure that you have tested the antibodies properly.
So one slide about islet antibodies. Initially, antibodies were measured by a rather tedious technique in which you cut sections of the pancreas and then stained it with fluorescent dye. And Dr. Shrikanta is sitting in front. He was a pioneer in the studies which were done for type 1 diabetes using some of these cytoplasmic and other early antibodies. But now most commonly we use these 4 antibodies against the different beta cell antigens: insulin, GAT65, tyrosine phosphatase, and zinc transporter 8. And out of these 4, actually the last 3 are commonly used. Insulin antibodies are only present most frequent in children and at early onset in childhood, and little more difficult to measure and not so well standardized. And usually if you measure the last 3 antibodies, GAD, IA2 and zinc transporter, studies have shown that you can measure almost about 95 to 98% of the different antibodies which are circulating. And now I'll just tell you in brief the results of a study which we did. This was funded by the ICMR, and it involved some other centers which I'll mention in the end. It was a multi-centric study, and it involved 76 patients with type 1 diabetes, whom we thought were type 1 diabetes, classically, less than 18 years of age. And we analyzed them within 2 weeks of their starting insulin. And we measured GAD, IA2 and zinc transporter antibodies, other than many other metabolic parameters, clinical parameters, genetics, etc. And we could, in summary, I can say that GAD antibody were present in 70% of these patients. If you added IA2, you got another 7%, so it became 77%. And then if you added zinc transporter antibody, it became 79%. So you were able to measure 21% were antibody negative. And this was considerably higher than what is seen in European Caucasians, for example, where it is about 5% or so. In different studies, it varies a little bit. And when we compared antibody positive and negative patients, so I'll tell you in subsequent slides that some of these patients with antibody negative diabetes had monogenic diabetes. So if you exclude these and then you compare antibody positive and antibody negative patients, there were no differences in any clinical features. No differences in the A1C, in the C-peptide, and other autoantibodies were also similar, like if you measure thyroid antibodies, etc. And also the HLA DR3 and DR4 frequencies, which are the most common HLA loci which are predisposing, they were also similar. And we tried to study their genetics in a little more detail. And we, with the help of CCMB Hyderabad, Dr. Chandak, we did the genetic risk score in these patients. And if you see, the genetic risk score is a composite of all the known different markers for genetic susceptibility in a disease. So all different, it includes HLA plus all other different loci which are known to increase susceptibility. And in this diagram, you can see that the on the left in blue are controls. Adjoining that in the pink, you can see are patients who have type 1 diabetes with antibodies. And adjoining that, type 1 diabetes without antibodies, and in the end, the last one are those patients who were diagnosed to have monogenic diabetes in this study. And you can see that between the patients who had antibodies, and you can, on the y-axis is the genetic risk score. And you can see that the genetic risk score is similar between patients who had antibodies and did not have antibodies. So basically they look like more or less clinically, genetically similar, similar groups. And this has also been shown in studies in Europe in children. But if you take adults, and you have adults with type 1 diabetes in adults, antibody positive and negative, the risk scores are different, because in those cases there is lots of admixture of type 2 diabetes. So in summary, I will say that patients who have antibody negative idiopathic type 1 diabetes form a considerable proportion, about 15 to 20%. They do not differ clinically or genetically from those who have antibodies. So then we went to the next step to study what proportion of these patients actually had monogenic diabetes. And monogenic diabetes has been, of course, studied very well in different countries. For example, in this Finnish National Diabetes Register, more than 6,000 children, diabetes was 3% were antibody negative, and 12% of those who were antibody negative had monogenic diabetes. But in Chinese, for example, a larger proportion were antibody negative, and almost 1/5 of the patients who were antibody negative had mutations. And the importance for studying mutations obviously is that you can give specific treatment to specific patients depending on what is their mutation. And the two common mutations or groups are those with MODY, which are autosomal dominant, and they are very well known: HNF 1 alpha, 1 beta, 4 alpha. These are the most common, which cause insulinopenia. Severe insulinopenia can present like type 1 diabetes. And then you have these various syndromic entities like Wolffram syndrome, which actually have other manifestations, but those manifestations may present at a later time. So initially when they first present, they may look just like type 1 diabetes. So when should one think of monogenic etiology? Some clinical clues are an onset less than 6 months, where you will have neonatal diabetes as the common etiology. A glucose which is not so high, requirement of small doses of insulin, and a history of early onset diabetes in 2 or more generations, or syndromic features like deafness or optic atrophy. And among the investigations, measuring islet antibodies is the most important investigation you can do. C-peptide is not that useful. It's only useful after 3 to 5 years, because C-peptide, as we all know, can be high even in type 1 diabetes for 3 years, 4 years, like that. And then there is a genetic risk score. So we had these antibody negative patients. There were 35 of them, and we performed NGS in 34, and we found that 12 of them had pathogenic or likely pathogenic mutations. And these mutations could be divided into 2 groups. The most common, surprisingly, were mutations in the Wolffram gene. 9 out of these 12. And the remainder were those in the classical MODY genes, HNF4 alpha, ABCC8, and PTF1A. So just to summarize, among all patients of type 1 diabetes, classical patients, less than 18 years of age, 21% were antibody negative. Monogenic diabetes was present in 7%, and Wolffram syndrome was present in 5%. If we compared the patients who had Wolffram syndrome with type 1 diabetes, they had similar clinical features. At that point in time, nobody could make out any difference, except that they had a little earlier age at onset and a decreased height SDS. Other syndromic features were not apparent at the time when we tested them at onset, except for ocular changes in one patient, mild changes. And this is just a revision slide for Wolffram syndrome. The commonest form of Wolffram syndrome is Wolffram syndrome 1. It's a very rare autosomal recessive disorder present in the European population in 1 lakh patients, individuals, sorry, not patients. The Wolframin gene has a role in the endoplasmic reticulum. It lies all around the endoplasmic reticulum, and it has a role in endoplasmic reticulum function and in calcium homeostasis. It's a progressive disorder. It affects multiple systems, especially the CNS, the pancreas, and the heart. Its earliest manifestations and the classical manifestations to make the diagnosis include insulin-dependent diabetes and optic atrophy. But they can develop progressively more manifestations, including sensory neural deafness, and diabetes insipidus, autonomic neuropathy, psychiatric illnesses. It's really a very unfortunate disease to have, and it has a poor prognosis, and currently there is no cure, but there are many trials now going on for different drugs to help to treat this, treat the disease. And it's a very rare disorder. I already mentioned that. In that study from Finland, which was there 6,000 odd patients, only 3 had Wolffram syndrome. In contrast, if you take a population where there's more consanguinity, for example, in Lebanon, out of 400 children, 5.5% had Wolffram syndrome, almost similar to what we are saying in this study. And when Dr. V. Mohan has just published his data on MODI, and which he has said that 12.5% of the MODI genes were actually due to Wolffram syndrome. And in Kashmir, they have diagnosed 7 patients over 10 years of follow-up of the patients of juvenile diabetes without autoimmunity. So in summary, 21% of insulin type 1 diabetes were islet antibody negative. They have similar clinical and genetic profile to antibody patients. 1/3 of the antibody negative type 1 diabetes had monogenic features. Had monogenic diabetes, most frequently Wolffram syndrome. Wolffram syndrome was similar to type 1 diabetes. Other syndromic features of Wolffram syndrome were absent. And it's imperative to diagnose this early for appropriate clinical care and genetic counseling. And it's essential to screen all antibody negative type 1 diabetes by NGS for monogenic diabetes. And I'd like to acknowledge Dr. Jayakrishnan, who did all the work from our hospital, and other colleges which participated, specifically Lady Harding Medical College and CNBC. Thank you.
The next presentation is by Dr. S.B. Madhu, who he was the past president, Research Society of Study of Diabetes in India, chief editor of IJEM, past president of ASI, several awards and orations, and over 320 publications. Over to Dr. V. Madhu for his presentation.
Thank you, chairpersons, and I thank the scientific committee of ESICON 25 to give an opportunity to present this talk and some of the work that we've done in this area. Mortality in type 1 diabetes, particularly in India, is a very rarely or scarcely researched or reported thing. And as you will realize, it has a lot of implications for the type 1 diabetes care in the country. What I'll be doing is briefly giving the problem of type 1 diabetes. We all know about the problem of type 2, but the emerging problem of type 1 is equally important to realize. What are the challenges of type 1 diabetes care in India? Mortality, the global trends, Indian trends, and what has been our institutional experience as part of the ICMR YDR study, and lessons for type 1 diabetes care. So that will be the broad scheme of things. The global burden, we all know, it's reported world over that it's rising. According to IDF, 1.1 million people in all ages have type 1. Wide variations, particularly low in China and Venezuela, but very high in Finland, we're aware of that. Large studies or registries like the Diamond and Eurodab have shown the trends of increasing, particularly in the younger stage group. Recent study actually shows that, this is seen much more than 1.1 million, 8.4 million across the lifespan 0 to 99, large chunk of them between 20 to 59, 1/5 less than 20 and 1/5 above 60, they're all type 1. So we'll be seeing type 1s at all age groups. That's another thing to remember. 1/5 of the individuals of type 1 are in the low income and middle income, low middle income countries, and India alone has about 0.28 million type 1 diabetics. And India belongs to the top 10 countries of type 1 diabetes mellitus and contributes about 60% of the global cases. And it's also known that the prevalence is expected to rise about 60 to 107% by 2040, particularly in the low income and the low middle income countries like India. Therefore, the problem is huge and we need to wake up and focus on this entity as well. What about the burden in India? India has the largest population, 2.29 lakhs of children and adolescents less than 19 years affected by type 1, and every year about 24,000 cases are being added. The ICMR registry found an incidence of about 4.9 cases per 100,000 a year in India. Of course, this is much lower than what's seen in US-based registries, but still it is significant enough. And further, the incident rates have risen over the years between 1990 and 2020, as you can see. There's also this problem of double diabetes, particularly important. We found in a study, an offshoot of the Young Diabetes Registry of ICMR, that 7% of them actually had double diabetes, features of both type 2 and type 1. And they seem to be more in those who had family history of diabetes and high BMI. So we need to keep this in mind. So the challenges are the rising numbers, high number of adults and middle-aged type 1 patients which we frequently encounter, poorly controlled glycemia and high burden of complications which need to face in our practice. The factor of double diabetes we need to keep in mind, perhaps more aggressive, and high premature mortality both early and late. And this is what I'm going to focus in the next remaining part of the talk, particularly the early premature mortality. The global mortality, type 1 contributes to a large part of premature mortality globally. Number of studies have shown that mortality is higher in non-diabetic, in specific age groups, comparative age groups, in several studies. And in fact, it's expected that many people live 12.9 or 11.1 years less in age-matched young non-diabetic adults. The search registry reported a short-term mortality. This figure is important to remember as we go along. Short-term mortality rate of about 103 per 100,000 patient years among type 1 patients. Just keep this in mind, and then we'll compare what is the figures in Indian studies. In India, it's been found that there's a range of life expectancy which has been reported in 10-year-olds with type 1 diabetes who were diagnosed, let's say, in 2021. It's a modeling study. It ranged from 13 years in low-income countries to 65 years in high income. That means in high income countries, the life expectancy is almost normal or near as much as non-diabetic individuals. Whereas in India, this is only 24 years. That means there's a shortening of 40 years from a non-diabetic person. So life expectancy for a type 1 diabetic, a 10-year-old who's diagnosed in 2021, for example, is projected to be 40 years less than a non-diabetic. In low-income settings, where access to affordability and care are limited, complications and early mortality associated with diabetes are very high. This is just a metric which I want to tell you because the subsequent slide is important. People have said that if you are able to look at mortality trends less than 25 years of age, in those who are aged less than 25 years, it's a good metric and tell you what is the avoidable mortality. That is an index of the avoidable mortality. If you go by that and look at this graph, you would find that, especially the lower, the green and the yellow, the high income group and high middle income group countries already, had stable lower mortality rates over the years, especially between 1990 and 2019. But if you look at the top two graphs or curves, they are either in the low income or the low middle income, their mortality seems to be still quite high. The decreasing diabetes mortality at ages younger than 25 years remains an important challenge in these countries. That means a preventable mortality in type 1 diabetes is still occurring at fairly high rates in countries like ours. And we need to do something about it. So we can do something about it, we need to do. It has been reported that over 97% of youth onset type 1 diabetes deaths are again in the low and middle income countries. In India, data is very scarce. Studies on mortality rate patterns are very rare. Only 2 studies of some importance I could find before the study that I'm going to present. One of which is from the SGPJ group, and Dr. Ish Bhatia is here. They were among the first centers to report from a single tertiary care center in North India, that is Lucknow, SGPGI, who also has access to a multidisciplinary team of management. So fairly good setup to manage type 1 diabetes, and yet they reported high mortality rates to the tune of 1100 per 100,000 patient years. We just saw 103 for the search study in the US. And this reports already 1100 per 100,000 patient years over 2549 patient year follow-up in patients with type 1 diabetes with onset of less than 18 years of age. And another study also observed, but they report fairly low deaths, 212 patients, but 22 deaths over 22 years. The SGPG study also said, emphasized inadequate glycemic control, high rates of hypoglycemia in these children, and unacceptably high mortality rate. Only 1/3 met glycemic goals. Severe hypoglycemia was frequent, and mortality was high compared to worldwide literature. So, what is this ICMR Young Diabetes Registry? This is basically a multi-center clinic-based national registry of over 18,000 patients of youth onset diabetes less than 25 years. And our center at UCMS Delhi enrolls cases from the north and east and central part of Delhi. Total number of YDR cases contributed our center is about 4,546, approximately 25% of all cases in the registry, and 3 centers, the Chennai Center, the All India Institute Center, and ours contribute about 80% of cases, just to show the numbers. Our center looked at the mortality aspect specifically, which was not looked into by the other centers of the registry. And this was published in 2024 at Diabetes Research and Clinical Practice. And again, it's a single center experience, but again has very revealing data similar to, or in fact reinforcing what SGPG had presented. Information on probable causes of death in each case was obtained through a verbal autopsy based on an ICMR standardized questionnaire, which was administered to the first degree relative who took care of the patient most of the time. And the final cause of death was reported as per the ICD-10. Out of 1294 eligible patients, mortality data collection started from 2012 onwards, and about 1,088 such cases were eligible from there, and then out of these, 898 were type 1. there were 105 deaths, giving a crude mortality of 11.6% with a mean follow-up of 6.4 years. The annual death rates, however, when you calculate a little more depth, were 13 per 1,000 per year, and an overall mortality rate was 2,945. Look at the figures. Per 100,000 patient years, and the median follow-up was only 2.6 years. Despite a reasonably low follow-up, yet the mortality rate seems to be very high. Those were the COVID years, so we thought probably part of it was being contributed by the COVID-related mortality, so we excluded those. And if we were restricted analysis to 7 years pre-COVID, even then the annual rates were 11.5 per 1,000 per year, and overall mortality rates still 3,128 patient years follow-up was 1,697. A little more, little more than maybe 1.5 times what Lucknow had reported earlier. And again, very low follow-up, even with a follow-up of a median follow-up only 2 years. So early mortality seems to be pretty high in type 1 diabetes patients. In a setting, ours also is a tertiary care center, and therefore it's alarming. So we report substantially higher proportion of deaths in type 1 patients than earlier studies. The search registry figures are 16 times lower than what we are reporting. And search also reported short-term mortality. The substantially lower mortality in search registries and registries from other high-income countries could reflect the advances of type 1 diabetes care, and that's what I'll be coming to shortly, particularly with respect to access to insulin, glucose monitoring, and healthcare facilities. These are three very simple measures which dramatically change the short-term mortality in type 1 diabetes. As far as the overall causes, the kidney complication infections, including tuberculosis, found to be the most common cause of death, apart from DKA. Again, highlighting the same thing. You need to have aggressive approaches to plug gaps in access to insulin and glycemic monitoring. And even the mortality from DKA indirectly suggests glycemic control issues. If you go a little more into analyzing within the group, 1/5 died within 2 years of diagnosis of type 1. So early mortality. 1/3 were aged less than 20 years. Over 40% of diabetes was diagnosed before 15 years of age. So young patients diagnosed less than 15 years of age, many of them less than 20 years, 1/3 less than 2 years of diagnosis. So a significant high short-term or early mortality. The excess early mortality, again, might be because of either more severe disease, high levels of brittle glycemia seen in adolescents, known to be seen in adolescents, or to poor insulin access and adherence in this age group, which is correctable. This was reported in earlier studies from all over the world as well. We can skip these. So what were the conclusions of this study? Broad conclusions. We found high mortality rates and excess early mortality in people with youth onset type 1 diabetes who are being treated at a tertiary care center, again with access to all multidisciplinary team. We have a good education, we give free insulin, and we have a good follow-up. We're part of a registry, so we keep tracking them. Yet we had such high levels of mortality. Kidney disease infections, including tuberculosis, are among the commonest causes of death, and urgent implementation of appropriate patient education strategies and efforts to optimize access to diabetes care probably are required, and we need to rethink our diabetes, type 1 diabetes care program even at our center. So what is the lesson, or what are the lessons in terms of type 1 diabetes care across the country from these three or these two studies, particularly the one that I've just quoted? What are the messages that we take? Early mortality is preventable. That's one thing we need to understand. That's how the high-income countries have reduced their mortality rates, have normalized nearly their lifespan. Early mortality in type 1 indicates that deaths have occurred before the onset of late complications and point to death from acute metabolic complications, including DKA and severe hypoglycemia, as was highlighted in both the earlier studies, from acute infections and early onset renal failure, both of which result from poor glycemic control. So it all boils down to the glycemic control, which is not achieved for one reason or the other in such type 1 diabetic individuals. These are largely preventable by ensuring access to free insulin or affordable insulin, glucose monitoring, patient education, and making available health services to promptly manage acute metabolic complications. These look simple on paper, but definitely if you are able to successfully implement these strategies, they'll go a long way in reducing mortality. Our tertiary care center in the capital of a country which provides insulin to diabetes patients, I said free insulin, has a robust patient education program. High early mortality even here suggests that we need realignment of the kind of program that we are doing as well. So what are the gaps which need to be addressed? Gaps in diabetes care across the country. If this could happen in 2 tertiary care centers, then you can imagine the plight in other centers across the country. Access to insulin is a major gap. Access to self-monitoring is another gap. And access to diabetes education is a third important gap. I think these 3 are most important. And 2 others that I've listed here is suboptimal use of late generation insulin pump, although it cannot be used widespread as we all know because of financial constraints, but there is still a lot of reluctance to even use them where they can be afforded. And absence of a structured national program of delivery of structured type 1 diabetes care, which is, I think, the need of the hour. These gaps need to be addressed if overall countrywide we need to make a dent on the early short-term mortality. In fact, this study showed evidence to suggest that, by simple core set of actions, early type 1 mortality can be largely prevented. We always believed so, and this actually gave the evidence for that. Just provide affordable insulin, provide good access to care, and provide health education. These 3 simple measures can drastically reduce early mortality. And hence we need to focus on these issues. The West Bengal model is one, since we're doing this SECON here, and many of you would be aware of the program going on here in several districts. It's one of the unique models and in several districts. We need to develop models like these, build on this model or alternate models of type 1 diabetes care, because it's high time we address this issue of mortality and morbidity in type 1 diabetes in a country. These are various, I don't go into the details of this program, but these models like these of structured type 1 diabetes care are the need of the hour. So the final conclusion from what I've said in the last 18, 19 minutes is that there is a need for a paradigm shift in our approach to type 1 diabetes if we are to optimize type 1 diabetes care in our country and prevent the large number of premature deaths we don't seem to know that are occurring. And only through systematic studies we have realized that patients just get lost, and when you actually go and look for why they are lost, many of them are dead. This is what we found through our study and probably the SGPGI. So many of them, what we don't even realize that there is a huge short-term mortality, we only call them loss to follow-up. In a systematic investigation, we realized that many of them account for mortality, and most of them are in children, adolescents, and short-term and soon after diagnosis. So it's time for action, and that's where I'll end. Thank you.
Thank you very much, Dr. Madhu. I think we need to certainly improve the type 1 care. Give them more insulin. Maybe we'll talk to our governments also. Monitoring is very, very important. We need to know that hypoglycemia and decay is very, very important. Because these 2 things they kill when they maybe the pulmonary diagnosis, tuberculosis can be diagnosed later on. Kidney can be protected if we treat them early. That's what I realized. Thank you very much. I think we are coming to last leg of the today's lecture, and we will be talking about more of a FCPD. And to talk about, we have Dr. Shiv Prasad. See, he's already here. He's Professor of Endocrine at Subgri Institute of Medical Sciences, Bangalore. And he's awardee by Torrent Young Scholar Award in 2009, Endocrinology, A.B. Gandhi Award, Excellence in Endocrine, 2010, International Osteoporosis Federation Young Investigator Award 2012, RSSDI Novartis Award 2013, and he has 40 scientific publications in national, international journals. Over to you, Dr. Ram, sir. Thank you.
Thank you, sir, for that kind introduction. Good morning, esteemed colleagues and guests. It's a privilege to speak today on a condition that remains under-recognized, yet deeply impactful, fibrocalculous pancreatic diabetes. Nestled at the intersection of gastroenterology and endocrinology, FCPD challenges conventional frameworks of diabetes management, demanding a nuanced understanding of its pathophysiology as well as its clinical trajectory. So today we turn our lens towards two critical dimensions of FCPD, the glycemic variability and metabolic parameters. In FCPD, where insulin deficiency coexists with malabsorption and deficient counter-regulation, glycemic variability is more pronounced and less predictable. So these fluctuations are not merely numerical, but have a profound implications on vascular health and long-term complications. So equally important are the metabolic parameters that shape the clinical landscape of FCPD. So in FCPD, we see a paradoxical association of severe hyperglycemia with low lipid levels. From brittle glycemic control to malnutrition to sarcopenia, the metabolic imprint of this condition is distinct and multifaceted. So as we look into these two dimensions of FCPD, let us aim to deepen our understanding of FCPD, not just as a clinical entity, but as a window into broader challenges faced in managing atypical brittle forms of diabetes in our resource-poor settings. So FCPD occurs secondary to chronic calcific pancreatitis. It's a unique form of diabetes reported primarily from tropical countries involving non-alcoholic young lean individuals hailing from a low socioeconomic background. It has a male predominance, and it tends to present with a classical triad of abdominal pain, steatorrhea, and brittle diabetes. So pain is, the onset of pain is usually in the adolescence, and steatorrhea typically develops in the second decade, followed by insulin requiring brittle diabetes in the third decade. So FCPD is marked by extensive fibrosis of the pancreas with large intraductal calculi, with a unique resistance to ketosis even in the face of severe insulin deficiencies. So genetic mutations, oxidative stress, malnutrition, and nutritional factors contribute to susceptibility, though the exact cause still remains elusive. Poor glycemic control leads to microvascular complications, very early onset microvascular complications, but macrovascular involvement is notably rare. So this is the diagnostic criteria proposed by Dr. V. Mohan. A key requirement is the need for evidence of chronic pancreatitis, typically in the form of pancreatic calculi on abdominal X-ray, or three of the clinical indicators, other clinical indicators like abnormal pancreatic morphology and ultrasound, recurrent abdominal pain since childhood, steatorrhea, or abnormal pancreatic function test. Importantly, we have to rule out other causes of chronic pancreatitis like chronic alcoholism or hyperparathyroidism, which can also be associated with calcification of the pancreas. So this diagnostic framework helps to distinguish FCPD from other causes of diabetes and pancreatitis. So we have to understand that. So the pathogenesis of FCPD is multifaceted and complex. There is a complex interplay of genetic, environmental, and nutritional factors. We don't know fully yet how it occurs. So genetic factors are the most important ones, especially the mutations in serine protease inhibitor causal type or SPINK1. So similarly, the mutations in chymotrypsinogen and trypsinogen genes have been implicated. The mutations in this gene will lead to premature trypsin activation within the acinar cells, leading to autodigestion, inflammation, and fibrosis. So the second factor is cassava intake. Early reports linked FCPD to the higher consumption of cassava. Cassava contains two toxins or cyanogenic glycosides, linamarin and lataustralin, which lead to generation of hydrogen cyanide. In people who are adequately nourished, these toxins are adequately processed. But in the face of malnutrition, there is deficiency of sulfur-containing amino acids like cysteine and methionine, which are required for detoxification of these substances. So cassava intake in the face of malnutrition can lead to excessive generation of hydrogen cyanide, leading to oxidative stress, lipid peroxidation, and acinar cell damage, protein flux, and calcification. So that is the second factor. We don't have any mechanistic evidence yet to prove that cassava intake leads to FCPD, but there is an the demographic or epidemiological evidence to suggest that this could be one of the contributing factors. So third factor is oxidative stress. Studies have noted higher levels of malondialdehyde, which is a marker of lipid peroxidation. Similarly, antioxidant deficiency, low vitamin C, and low vitamin C have been noted in FCPD, contributing to oxidative stress, impaired pancreatic repair, and calcification and acinar cell damage. The fourth factor is the protein energy malnutrition. So it contributes to pathogenesis in more than one ways, starting from reduced or inadequate processing of toxins, elevated oxidative stress, reduced trophic support to pancreatic acinar cells. Some studies have found that in protein energy malnutrition, hormones like growth hormone, which are needed for acinar cell support, are deficient. So the protein energy malnutrition is the fourth factor. So all these factors interact in a complex manner, first leading to pancreatic exocrine insufficiency, followed by secondary beta cell damage and FCPD. So just a brief about epidemiology of FCPD. If you look at the data from 90s, FCPD was a dominant form of youth onset diabetes. Second only in prevalence to protein deficient diabetes mellitus in India, and even more common than type 1 and type 2 diabetes. This was the data from some of the major centers from across India in 1990s. But if we look at the recent ICMR youth onset diabetes registry in 2016, pancreatogenic diabetes per se contributes to only to 1 to 2% of all the cases of youth onset diabetes. So the prevalence or the incidence of this FCPD seems to have gone down parallel to the improvement in nutrition, but we still see quite a few cases, especially in certain pockets of India, where it appears to be still relatively common. So the key to deciphering glycemic variability in FCPD lies in unraveling the defects in insulin secretion and insulin sensitivity. So the C-peptide levels in FCPD are between that of type 1 and type 2 diabetes, highlighting intermediate insulin secretory capacity. Significantly impaired, but not as severely as in type 1 diabetes. So we then looked deeper into the insulin sensitivity and secretion in patients with FCPD, first by assessing plasma glucose and insulin responses during an OGTT, and compared with type 2 diabetes and control. FCPD depicted here in blue color showed markedly elevated plasma glucose levels with blunted insulin responses as compared to controls and the type 2 diabetes, suggesting, indicating impaired insulin secretion. We then compared the indices of insulin sensitivity between these two groups. We estimated static indices like OMA-IR and QUICKI, which reflect hepatic insulin resistance, and dynamic indices like Matsuda ISI, ISIK, OGIS, and Stumwall index, which provide information both on hepatic as well as peripheral insulin sensitivity. These dynamic indices employ various modeling methods in order to estimate insulin sensitivity during the course of OGTT. So some of these have the ability to adjust the insulin sensitivity for the underlying beta cell defect, so which is critical in a setting like FCPD where insulin deficiency is a predominant factor. So the values for this matrices in FCPD were intermediate between those of type 2 diabetes and controls, closer to controls than type 2 diabetes, indicating a relatively preserved insulin sensitivity. So we then went on to compare the indices of beta cell function in FCPD between the three groups. Again, static indicators like OMA-B and dynamic indicators like insulinogenic index and oral disposition index. Here we find that FCPD, the levels for these indices in FCPD are lower than both type 2 diabetes and control, indicating severely impaired beta cell function. So severe insulin deficiency is the primary defect in FCPD, Lower insulin sensitivity has been reported, but not consistently. Wherever it has been reported, the contributing factors were chronic inflammation, altered lipid metabolism, and micronutrient deficiencies. So we explored our different aspects of glycemic variability in FCPD. First, we compared CGM-derived measures of glycemic variability between FCPD and type 2 diabetes. Across multiple matrices such as standard deviation, mean amplitude of glycemic excursion, mean of daily differences, FCPD patients exhibited significantly higher glycemic variability than those with type 2 diabetes. This suggests that FCPD is associated with more erratic and unstable glucose pattern. If we specifically look at the MAGE values, the MAGE values are significantly higher in FCPD, indicating greater glycemic variability, again highlighting the erratic and brittle nature of glycemic control in FCPD patients. So FCPD is associated with a brittle glycemic profile with erratic fluctuations between hypo, normal, and hyperglycemia. They have pronounced postprandial spikes, and they spend greater time in blood glucose values above 180. So underlying factors for this brittle glycemic control are beta cell damage, which leads not only to insufficient but also to erratic insulin release. There is heterogeneous glucagon secretion, which contributes to postprandial hyperglycemia. Exocrine deficiency leads to erratic nutrient absorption as well as altered glycemic kinetics. Finally, autonomic dysfunction and in long-standing cases, delayed gastric emptying may also contribute to this glycemic variability and brittle glycemic control. From a diagnostic standpoint, implications of this pronounced glycemic variability include that HbA1c is not a reliable marker in FCPD. It misses critical swings of postprandial spikes and hypoglycemic episodes, potentially underestimating the risk. CGM plays a greater role in assessing glycemic control. It captures glycemic variability, it monitors hypoglycemic risk, it guides personalized insulin therapy, and also tends to improve time in range. So for the management of patients with FCPD, we should make usage of CGM and its benefits. So this is a typical CGM graph of patients with FCPD on the top and type 2 diabetes in the bottom. You can see steeper glycemic slope in FCPD as compared to type 2 diabetes. And you can also appreciate much pronounced and wider postprandial glucose excursion in FCPD as compared to type 2 diabetes. In general, also note that FCPD patients tend to have more erratic glycemic pattern throughout the day as compared to a more predictable pattern in patient with type 2 diabetes. So hypoglycemia again is frequent in FCPD, especially during the night time due to the impaired counter-regulatory mechanisms like defective glucagon release, malabsorption related erratic nutrient absorption, as well as autonomic dysfunction. So studies have shown that nearly 75% of FCPD patients have evidence of hypoglycemic unawareness, just like we see in type 1 diabetes. So predisposing them to frequent hypoglycemic episodes as well as more severe hypoglycemic episodes. So this poses challenges in insulin titration and also increases the risk of neurological damage due to severe hypoglycemic episode. So we also looked into CGM-derived indices of hypoglycemia between FCPD and type 2 diabetic patients. So although the frequency, the number of episodes of hypoglycemia were more common in FCPD as compared to type 2 diabetes, the values for indices like time spent below 70, area under the curve below 70, low blood glucose index, which is an indicator of risk of severe hypoglycemia, were not statistically significant. The main reason were the prevalent HbA1c in the FCPD group was close to 10. So had we been successful in achieving euglycemia or near normal glycemia, probably we would have appreciated difference even in this matrices. So achieving glycemic control was such a difficult task. So we could not demonstrate significant difference in this between these indices in comparison to type 2 diabetes. So coming to the second part, metabolic features of FCPD. Insulin deficiency and brittle diabetes lead to poor glycemic control. Exocrine deficiency and low socioeconomic status lead to low BMI and malnutrition. Fat malabsorption leads to lower lipid levels. Severe beta cell dysfunction mandates insulin as the mainstay of therapy, and there are associated micronutrient deficiency. We compared the clinical features of FCPD with a large cohort of type 2 diabetes. The mean age at diagnosis of our cohort was 30 years for FCPD and 44 years for type 2 diabetes. There was a male predominance in FCPD. The mean BMI was 19 close to 19 in FCPD and little more than 25 in type 2 diabetes. And family history and hypertension were much less common in FCPD as compared to type 2 diabetes. If we look at the biochemical characteristics, it revealed significantly poorer glycemic control in FCPD, especially the higher postprandial glucose values and elevated HbA1c. So FCPD patients also showed lower hemoglobin and creatinine, and the lipid levels were much lower in compared to type 2 diabetes, underscoring a distinct pathophysiology and nutritional challenges as compared to type 2 diabetes. So studies have also shown that lower fat percentage in FCPD in comparison to type 2 diabetes. We also looked at intra-abdominal adipose tissue in FCPD, and we found that, and also the visceral fat area. We found that visceral fat area in FCPD was lower than both type 2 diabetes and healthy controls, suggesting that insulin resistance may not be a prominent character in FCPD. So if you look at the macrovascular complications, they are less common in FCPD, especially in comparison to type 2 diabetes, whereas microvascular issues, especially diabetic peripheral neuropathy, are notably higher. So studies have also shown high prevalence of cardiac autonomic neuropathy in FCPD ranging from 20 to 30%. So we need to bear this in mind. And the risk of pancreatic cancer is significantly increased. It is increased by 100-fold, which is a very high number. So head is more commonly involved. It is heralded by the development of obstructive jaundice, unexplained weight loss, and sudden worsening of pain. CA19 is elevated in 70 to 80%, but mild to moderate elevations can be seen in pancreatitis per se. So serial measurements may be needed, and we have to see the CA19 levels in the overall clinical context to interpret its value. So studies have shown that pancreatic enzyme replacement therapy dampens glycemic variability, stabilizes postprandial glucose level, boosts incretin hormone response. However, only a modest HbA1c reduction has been demonstrated, with some reports suggesting it may also reduce hypoglycemic episodes. So the disturbances in the metabolism that I showed fuel a vicious cycle of malnutrition, cellular damage and sarcopenia, contributing to early onset diabetic neuropathy, along with an heightened risk of pancreatic cancer. So the cumulative impact underscores the need for comprehensive nutritional and metabolic management in patients with FCPD. So I would conclude by saying FCPD exemplifies a uniquely complex subtype of pancreatogenic diabetes, where the convergence of endocrine insufficiency, pancreatic exocrine dysfunction, autonomic dysregulation, and nutritional defects creates a multifaceted clinical challenge. So the resultant brittle glycemic profile and pronounced glycemic variability leads to increased risk of microvascular complications. Similarly, the metabolic landscape characterized by low BMI, micronutrient deficiency, and poor glycemic control increases the risk of DPN and pancreatic carcinoma. Encouragingly, PERT and individualized insulin regimens have shown promise in management, providing relief to both metabolic as well as symptomatic burdens. So multidisciplinary approach, individualized insulin therapy is key in improving the quality of life in patients with FCPD. So I will stop here, and thank you for your kind attention.
And exocrine deficiency has to be dealt with. That's what I learned from you. Micronutrient deficiency could be cause for the neuropathy. That's what you told. Thank you very much. Have a seat, please. So I think house is open for discussion. Before you ask a question, I have a question for Dr. Bhatia. Do you advise in all type 1 diabetic patients to go for the antibody test?
I didn't used to advise, but now I advise. At least to go for the GAD antibody, because that will pick up 70% odd of the... Previously, I didn't used to do it. But after our own results, I don't know.
So, question for Dr. Bhatia. So, in the antibody negative patients, have you had the chance to follow them up longitudinally to see whether they become positive later on? And historically, is there any data that those who are negative, say 10 years, 20 years down the line, do they remain negative or they become positive later on? And the second part of this is, this group is neglected because in the clinical trials, they are excluded because they don't have antibodies. So is there any difference between outcomes, microvascular complications, insulin requirements, say 10 years, 20 years down the line between antibody positive and antibody negative type 1?
So I don't think that.
Can you put the mic on?
The antibody negative patients, do they become positive later on, or what proportion of them become positive? We don't have that data from our own study. We haven't checked them again on follow-up. And usually we take quite a high, like if you have a cutoff titer of 20, then we actually usually take 40 or some other titer to actually say that they are positive. We don't take very low titers because so I don't know the answer to that question. And I don't know the answer to that from literature also, so I'm sorry, I'll have to tell you later. But also I don't think there are many studies, like you said, one of the main reasons for only those patients who are antibody positive, they are included in studies for any immunotherapy, because antibodies are one of the things which are followed, C-peptide, what happens to their C-peptide, etc. Only those patients who are antibody positive are actually put in these trials so that they have a uniform group of patients of type 1 diabetes. And so now that there is data that both antibody negative and positive patients have similar genetic profile, not only this study that we have done, but much larger studies are there, I think that they should be included in these trials. Whether there is a difference in their clinical, what happens, the rate of fall of antibody, rate of fall of C-peptide or complications, that I don't know.
Thank you.
I don't think there's a study which I have read.
Madhu sir, good morning. Good morning. In my day-to-day practice, I have the patient party say double pneumonia, double typhoid. In last 1 year, we had double diarrhea. Right, sir? Now, today, from your side, is a double diabetes. Sir. What is this, sir? What is the treatment, and when double diabetes develop? Please say something, sir.
I just mentioned, these are patients who basically have, features of type 2 diabetes and type 1 diabetes combined. That means they have a type 2 diabetic phenotype. They have a strong family history of type 2 diabetes. They have a, like BMI, as I told you. And they also have, in many cases, C-peptide levels which may be high, but initially that can be possible in type 1 as well. And they may or may not be antibody positive. Most of them are, by definition, antibody negative. So these patients seem to be having, although there's not large data, they could be having a combination of the two, and they're more aggressive and more risk of complications. So you should be more careful about that group. That is the implication.
Sir, what is the treatment? Treatment, sir, treatment.
Treatment is the same. Treatment is just like any type 1 patient, but you need to be aggressive and follow up for complications, screen for them, and be aware that they can have a worse prognosis.
Thank you, sir.
Type 1 diabetics, after certain periods, maybe 10 years, 20 years, they put on a lot of weight and they have insulin resistance. They behave like type 2 diabetes. I have a couple who is, 25 years diabetic, both type 1, and they put on a lot of weight. It's difficult to control. They have undergone bariatric surgery. Now both of them are doing, and the lady conceived after bariatric surgery, so that is also there. So maybe that you can call it double diabetes. Over to you, madam, please.
The question is to Bhatia, sir. Sir, we get patients in 20s, maybe 28, 29-year-olds who are on insulin for 10 years, or maybe no history of ketosis, family history of early diabetes in one of the parents. So would you advocate antibody test or a genetic testing to rule out MODY, because if it is HNF1 alpha, sulfonylureas might take care of it.
So this patient had, you thought type 1 diabetes at onset?
No, you don't know it's a type 1 diabetes because no antibodies, no C-peptide levels are available, but the patient is on insulin and there's no history of ketosis. The family history is of early diabetes in parents also. So would you advocate, when you see at 5-6 years down the line, would you advocate antibodies or would you try to do genetic testing if the patient is affording?
No, I think you would like to make sure that many antibodies persist. Like GAD antibodies the titer doesn't fall with duration or falls very little bit with the duration. And so you can certainly do GAD antibodies to then make sure that the patient doesn't have type 1 diabetes. And then if the family history is really quite significant, that the parents have one generation or 2 generation history of early onset diabetes, then you can certainly try to screen these patients with so if he is antibody negative and this history is there, then you could consider
genetic testing.
And yeah, I think that I would definitely do antibodies.
I have a question to Professor Madhu. The important cause of mortality in type 1 diabetes may be celiac disease, coexistence. Frequently, the celiac screen is not that meticulously done, and other hormonal deficiency in the setting of polyglandular autoimmune syndrome may be instrumental for also increment in mortality. But in our hospital, we screened a lot of patients, some group of patients for celiac disease. Asymptomatic celiac disease also we got. So what is your take?
Your point is well taken. It's a routine these days wherever available to screen for celiac disease in all type 1 diabetes patients, and it's a standard protocol at our center as well. So, and if at all they turn out to be celiac, some of them do, you appropriately manage them, whatever problems are related to celiac disease. But the mortality data that I presented was independent of that. It was a short-term mortality and not related to celiac disease. And therefore, it's even more alarming. But you're right, celiac disease is an important contributor. One should screen all young diabetics, particularly type 1 for celiac.
And another question to Professor Bhatia. The antibody testing, which antibody has the worst prognosis? Suppose in resource constraint area, lot of all the antibodies you have eluded may not be possible to take up for investigation. So GAD 65 or the Jing antibody or IA2, which one you recommend first in a resource constraint?
Yeah, I would advocate to do the GAD antibodies, but I would say that different labs don't do it as well as, so one lab doesn't do it as well as another, so it's a good idea to actually the lab which does this antibody testing, they should be using kits which are standardized by taking part in a international program. And so you should try to send the antibodies to a good lab, which you think is a good lab, rather than to send it to the cheapest lab, because it is costly.
Dr. Madhu, is there any facility for the type 1 patient, I mean the governmental facility, so that they get access to the antibody testing free of cost?
No, I don't think the government at the moment is subsidizing or offering free antibody testing, because it is not yet standard of care. Although data is emerging that, in certain set of patients, it might be useful to do, and type 1s where you have high suspicion, you might need to do, but as yet it is not standard of care, so government will not subsidize. antibody testing at the moment.
May I just have one question to the last speaker? Because the brittle diabetic FCCP, very fluctuations of post-bundle and otherwise, actually we should have a lower HbA1c. As you have pointed out, a higher HbA1c is being seen in most of the cases. So what is the reason?
So main reason is as soon as we give insulin, they also get hypoglycemia. So that prevents us from appropriately using insulin to achieve hypoglycemia without having hypoglycemia. So we end up under-treating. So plus this lack of incretin, so severe beta cell deficiency, we are not able to give enough insulin. All these factors contribute to and erratic nutrient absorption due to malabsorption. All these factors contribute to very high HbA1c. When we try to control them, when we try to bring them to normal glycemia, that is when we start seeing more hypoglycemic episodes. So if you leave it like that, they are happy, but that will lead to poor glycemic control.
I have got a question for all of three. Is there any pre-diabetic phase in type 1 or FCPD or your monogenic one? Because in that case, we can diagnose them before they get diabetes.
Yeah, so now it's very well known. In fact, Dr. Srikanta, who's sitting here, actually was the pioneer in some of these studies which were done. That you have different phases. It's now well recognized, and there is a statement which has been made by the American Diabetes Association, and you have the initial phase for type 1 diabetes, which starts many years earlier, where you will have no antibodies, only a genetic predisposition. The next phase you will have antibodies, but your metabolic parameters will be normal. And then you will have a phase in which you may have just an altered A1C or an altered patient not symptomatic. And finally you have symptomatic patients. So one of the really good uses of these antibodies and other markers is to diagnose type 1 diabetes earlier, which is more easily feasible for relatives because it is more frequent in relatives than in the general population, and use these antibodies as markers for that phase so that you can start treatment at an earlier stage. No, I don't know for monogenic if there is a phase like that. They are two different kettle of fish. And type 1 diabetes, everybody knows, has a small or long period before the diabetes is apparent. And monogenic diabetes, I don't think there is a period like that which has been studied. FCPD again is a different
There is a pre-diabetic condition, chronic calcific pancreatitis. So not everybody with chronic calcific pancreatitis will go on to develop FCPD. A major proportion. So you can consider that as a pre-diabetic phase. The problem is even this chronic calcific pancreatitis cannot be reversed. So even if you get to know that patient has chronic calcific pancreatitis, so which is considered as a pre-diabetic phase for FCPD, we don't have enough intervention, or we do not have enough scientific knowledge how to tackle this problem in order to prevent the onset of diabetes.
A question to Dr. Madhu. In type 1 diabetes, often there is in terms of mortality, there was a phenomenon called dead in bed syndrome, where it was postulated that hypoglycemia overnight might have caused the mortality. So in the registry, in the study, hypoglycemia could have caused the mortality, or it was unknown. It was not tuberculosis, it was not renal failure.
Hypoglycemia was an important cause, but the specific entity that you are reporting was not found. But yes, hypoglycemia did contribute both in our study as well as in Dr. Isha's study from Lucknow. One of the major causes, brittleness of the diabetes causing both hypo and hyper, contributed to mortality, certainly.
Thank you very much, all the speakers and organizers. Thanks a lot. We close the session now.
Thank you very much for this wonderful deliberations of the topics. Now we'll be having next topic, that is type 1 diabetes beyond insulin. For the session, I would like to call upon stage Dr. Ashok Kumar and Dr. Amurtha Shankar Chaudhary as a chairperson.
Thank you, organizers. I think we had a very nice session with very senior and experienced professors speaking on young onset diabetes, including type 1 diabetes. If you have heard them very intently, you can hear the emotion in their voices when they speak about type 1 diabetes. These are the group of individuals who need special care, attention, empathy, at the same time correct treatment so that we can improve their, not only just the glycemic control, but also can improve the quality of life. And hence endeavors continue to find newer treatment modalities, ways to prevent or even delay the onset of development of type 1 diabetes, finding newer treatment modalities, non-insulin based therapies. We have had wonderful advances with GLP-1 receptor agonists being studied along with insulin, and also sometimes beta cell replacement. So to talk about these, take us through these, we have a set of 3 wonderful auditors who will give us more ideas about these less known facts about type 1 diabetes. So to start off, I'll be requesting our first speaker, Dr. Joe George, to come up to the stage. He'll be speaking about disease modifying agents. Can we prevent type 1 diabetes? He's a very good auditor, senior consultant endocrinologist director at EndoDiab Group of institutions, more than 22 years of experience, DM FRCP. He's also the secretary of RSSDI Kerala. Excellent academic achievements. He was the best outgoing postgraduate student of KEM Hospital in the year 2006. Dr. Joe George, the stage is all yours.
Thank you, sir, for the kind introduction. From a session which included the passionate discussions and clinical features and how to go about in the clinical aspects, we are moving to something where the difference between you and me is that I've just read a few days back the same topic. It's going to be a pure as a conflict of interest. Let me tell you that I don't have any practical experience of any of these treatments which I'm going to discuss, just that I've read the theory, just like you people, you would have done it, because we don't have any of these treatments in our practice. So we all know, it was discussed in detail, that managing type 1 diabetes is a very tight rope. There is hyperglycemia and its complications on one side, and hypoglycemia and its complications, which include psychosocial, financial, and morbidity and mortality on the other side. The studies which have been done show a very dismal picture. One of the studies which I have just shown here, which shows that average participant or patient with type 1 diabetes has a dismal control by the HbA1c standard, not even by the time in range standard. A1c standard itself, you can see that all over the world, whatever maybe the age group, you can see that only around 20 to 25% are having the target, have reached the target A1c of less than 7. Glucose monitoring metrics have been, the time in range is now the standard of care. And when you look at it, there are also things don't look that beautiful or something to be, yeah, definitely we are improving, but from the multiple daily injections where the time in range on an average has been 54% to sensor unintegrated pump where the time in range is around 55%, which improves with the sensor augmented insulin pump to 60%, and automated insulin delivery where it moves to 75 to 85%. But finally, all these things are there as metrics because we are not able to do it perfectly fine. Ideal thing would be to have a, what should be there? Recent hypertension guideline actually wants to say that the BP should be less than 120. Why? Because that's the normal, isn't it? So when you think of a target, say that a patient of A1C less than 7 is having a good control, actually it's actually showing our inability to control it to the normal value. What's the normal A1C? It should be 5.6, isn't it? So a patient, if I really say that the person is in good control, he should be in the non-diabetic range. That's ideal. That's when we can actually say that the glycemia has fully normalized and our patient, we are giving the perfect care. Our inability to reach that is actually presenting ourselves to put the guideline at a upper level with a A1C of 7. So when you look at managing type 1 diabetes, we know that it's the damage to the beta cells and the patient doesn't have beta cells anymore and he has to survive without it. But the best way, whatever may be the advances that are going to come, nothing is going to be comparable to a normal beta cell. And best way to have a normal beta cell is to prevent that beta cell destruction from happening. You cannot remake it, may not be that ideal as to remake the beta cell. So, but we have been taught time and again that type 1 diabetes is something that cannot be prevented, and it cannot be, it's also not something that can be cured. So, but recently there have been a lot of progress, and we know now that there's a drug which has been approved, that is teplizumab, which has been approved to delay the onset of type 1 diabetes. Actually, the last session there was a question which I would be answering in the following slides as how to detect it in the preclinical stage. Because if you want to prevent diabetes, we should know why exactly the beta cell is getting destroyed and how to detect it before the disease comes up. Otherwise, it's not prevention, isn't it? Preventing diabetes means you have to prevent it. When I was doing DM or MD and DM, it was said that it's an immune mimicry, that our own immune system damages the pancreatic cells and the patient loses everything, and the loss of immune tolerance is all the thing that happens. But as the research progressed and the experience progressed, now we know that it's not just immune tolerance. It's a complex involvement of both genetic, immune, and environmental factors that finally lead to the loss of immune tolerance. It is now identified that a dying beta cell probably contribute to the formation of those antigens, and even the beta cell can by themselves present as the antigen presenting cells and propagate the damage to themselves, finally leading to the problem. So it's not just the immune system that is at problem, it's also the beta cell that's at the problem. And what initiates, what propagates, and what finally results in the end results, it's a mixture of everything. That's why when you look at the proposed chart of type 1 disease vulnerability, you can get a very, very busy slides because there are so much research going on in this aspect. It's not that people are sitting behind just thinking that let it be like that, it's their fate. No, there is a lot of disease research that is going on where each and everyone has found out something or the other which could probably contribute to the disease vulnerability. And why are we not reaching the cure? The reason is the same slide. Because there are, when you see multiple points which could be a problem resulting in the final outcome, it's very difficult to attack each and every thing, and there are 100 thieves around, which one stole the thing, it's very difficult to predict, isn't it? It's something like that. So yeah, here we have a preclinical stage also. I'll be discussing it in a bit because the preclinical stage, that is where the primary prevention stands, where we know that there is a genetic contribution based on the HLA class 2, basically DR4, the DQ2 and DQ8 of DR4 and DQ2 and DQ3 of DR3, DQ8 of DR3. Along with that, environmental factors like virus, diet, and immune factors and loss of tolerance, which could be leading to type 1 diabetes. Then it forms to the stage 1 diabetes. Here again, we should understand that stage 1 diabetic, the patient is asymptomatic and is normoglycemic. But the patient has one or more of islet antibodies which is present. Even at that time, the risk of prediction is not very good because it is said that 35 to 50% of progression in 5 years. So that is less than half of them. So a person who is having an autoantibody, one single autoantibody, it is said that the chance of progression to type 1 diabetes is only 15%. So it's very difficult to predict at that stage. So 2 or more, then the risk of progression becomes around 35 to 50%. In the stage 2, you have 2 or more with dysglycemia. That becomes stage 2. Then the risk of progression is quite high with 75% progression in the 2 years. By the time the patient reaches stage 3, that's a clinical diabetes with overt hyperglycemia, there is antibody positivity, and you need insulin for management, and all the osmotic symptoms and the classical symptoms of hyperglycemia is there. So that becomes tertiary prevention only. And stage 4, that's one thing that we do manage every day. There are a lot of studies. It's not that we are, again, there are a lot of studies with various things that has been hypothesized and put into practice. There have been studies looking into how they contribute to it, like low milk protein, bovine insulin, gluten, how does it affect nicotinamide, and also on drugs which have been tried over the years. The progress has been rapid over the last decade. That's a good thing, because now we do have certain disease-modifying therapies and features linked to it and its response in type 1 diabetes prevention. And from this review, you could see that a lot of things like gluten exposure, insulin-free whey protein versus cow's milk formula, and whey hydrolyzed formula, inhaled nasal insulin to produce immune tolerance, oral insulin to produce immune tolerance, and GAD alum injection to again produce immune tolerance, and teplizumab finally, which has been successful. So here you can see that from the confidence interval, which is the successful thing. Teplizumab is definitely there, and other thing which is successful is cow's milk formula, the avoidance of cow's milk formula. That is one thing which has been found to be beneficial in preventing type 1 diabetes. That is the only data which is available. So when you look at the targets of treatment, again, that's a big confusion and big complication scenario. Why? Because it's not just the beta, it's not the immune system at fault. It is not just the beta cell at fault. It is a combined fault in both that is contributed by genetics, supported by environment, and what happens where we still don't know. And again, we have a very complex set of slides where there are so many areas have been identified where probably you can have therapeutic interventions in the endocrine cells, that's the beta cells. And also there is another lot of points of care where you could have therapeutic intervention in the immune cells also. So there are so many things happening, so many hypotheses happening, but it's not a single way. One thing that we should recognize is that type 1 diabetes still is not just one pathway of moving from one to the other step, then to the other step. There are various attacks which could probably result in type 1 diabetes, initiated from various aspects, but the final common end result is that the loss of beta cell. So with this, I would be just touching upon a few studies which have come up in the last decade, which shows us the way, probably the way forward that is coming up in our practice. So the first one of them which I would like to highlight is one thing which came in NEJM 2019. This is a landmark study because this is the one which has finally led to the treatment, US FDA giving approval for preventive treatment of type 1 diabetes. Here I am standing here talking to you about prevention of type 1 diabetes. Why? Because we do, at least theoretically, we do have a therapy, though expensive, it is said to be around 2.5 CR for a treatment. So though expensive, it is there, something that is there. I'm not saying that we can afford it, but the thing is that that is the way to the future, and maybe it becomes affordable later on. So this is a trial, that is the teplizumab trial, which is an anti-CD3 antibody, and it was given to relatives at risk of developing type 1 diabetes. Here the eligible participants were non-diabetic relatives of patients with type 1 diabetes. They had to have 2 or more diabetes-related autoantibodies detected in 2 samples obtained within 6 months before randomization. They had to have dysglycemia in oral glucose tolerance test. So they were relatives of type 1 diabetics who were not yet diabetic. In this phase 2 RCT, so the teplizumab was given to subjects in a single course of 14 days versus the placebo, and OGTT was performed to see how the response was. And there was, what you can see very clearly, that teplizumab had a better outcome as compared to the placebo. The hazard ratio was 0.41 with the upper confidence interval being 0.78. That is significantly beneficial. So annualized, finally, what did this study show? In those preventive aspects, it was, see, one thing you have to understand that how difficult it would have been to identify the patient. Relative, and that too without diabetes, who are likely to develop diabetes. So it was a very difficult study, I would say. So from this study, it was shown that the annualized rates for diagnosis of diabetes was 14.9% per year in the teplizumab group versus around 35% in the placebo group. That's great. And what do you see in this graph? There is still patients who are progressing. The beta cell is still continuing to come down. It is not a permanent stoppage of the beta cell damage, but it has delayed the beta cell damage, and we do have data up to 3 years follow-up, which the continuous effect of the drug was reported with the average delay in type 1 diabetes diagnosed at 3 years. So up to that it is delaying the damage to beta cells, but it is not stopping it completely, it is not reversing it completely. But some hope it was shown, and because of this study only they got the FDA approval. Then another study is the NEJM 2020 golimumab study and beta cell dysfunction. Here the patient group was a patient with type 1 diabetic. Here, see, golimumab is a IgG1 kappa monoclonal antibody specific for human TNF-alpha and is approved for the treatment of rheumatoid arthritis, ulcerative colitis, juvenile idiopathic arthritis, etc. And TNF-alpha has been shown to have a significant role in development of autoimmune diseases and is said to be directly toxic to pancreatic beta cells. And it is been shown in earlier studies that patients with type 1 diabetes tend to have an elevated TNF-alpha level. So here again it was an injection, phase 2 trial involving children who was recently diagnosed, and they were given the injection followed by maintenance dose for every 2 weeks for 1 year. And again, what did you see? You can see almost similar kind of results, but this is after onset of diabetes. The earlier was before the patient was had dysglycemia. So here golimumab resulted in better endogenous insulin production than placebo. So imatinib was another study in diabetes, in the recent onset type 1 diabetes, which came in Lancet 2021. Again, the type 1 diabetic within 100 days of diagnosis with an insulin stimulated C-peptide level which was more than 0.2 nanomole per liter during the mixed meals test was selected, because you should have some C-peptide there to look for prevention. If that's not there, then there is no use trying for prevention. In this study also, it was after 26 weeks of treatment of imatinib, which is a tyrosine kinase inhibitor, there was decrease in beta cell reduction or damage or sustained, which was further sustained for up to 24 months. Teplizumab is the drug which got approval. You have another study, because see, finding the earlier cohort, I told you that was a humanly impossible, almost impossible task of finding that patient in your clinical practice. So that initial study you cannot replicate in clinical practice. So this was the same drug which was given in newly diagnosed type 1 diabetic patients. It was a multicentric study where they were randomized to patients having a lower C-peptide value to a higher C-peptide value. And also they were given 2 12-day courses of IV teplizumab. And it was seen that it also improved the C-peptide levels at week 78 in stage 3 type 1 diabetic patients. And you can see that the C-peptide value was much better in the treatment group. So even at the onset of diagnosis, within the first 100 days of diagnosis, teplizumab was doing the thing. Only thing is that by the time the beta cell damage has already progressed. But this is again something that is doable. And finally, all these are IV injections you have to give as a infusions, and it's under supervision and all those things. The last study which came in NEJM is looking at baricitinib. It is a JAK1 and JAK2 inhibitor, which has been used for treatment of rheumatoid arthritis and alopecia areata. The advantage of this is that it's an oral drug and which can be given. So here again the JAK1, JAK2 has been found to be significantly involved in the development and progression of diabetes and beta cell damage. And giving this drug, it was found that there was 48% increase in the median mixed meal stimulated C-peptide level within the treatment arm, and the effect, whatever the effect was, seemed to be similar to whatever was obtained in the previous IV regimes. So this is an oral drug which has produced a similar effect. So now you have a lot of drugs which are in the pipeline or under research, may not be practically applicable, because see, all these things are not arresting the progression but delaying it, but the downward trend is still continuing at a slower rate. So how long to continue is a big question mark that is there. Just delaying it for a few years, how much does it benefit? We all know that it's going to be a lifelong disease. So we need to have something much better, but it's a new ray of hope that has come in, and probably the next year or the year after we may be coming in the same stage at a different venue and talking that, yes, now we have something which has completely prevented. So, but here we do have drugs which are like on effect on beta cells. Other studies which I am not quoting are drugs like verapamil, baricitinib, and IL-21 and liraglutide. And effects via immune system, we already discussed teplizumab, abatacept is there, and antithymocyte globulin, rituximab has been studied. So how much do they compare? When you use these studies, multiple studies, multiple drugs, and multiple parameters, how do they compare in the beta cell preservation across the clinical trials? See, here we should understand that you cannot compare apples with orange. The study criteria, inclusion criteria has been different, but recently we do have areas where we could compare like the C-peptide level, which has been there after the year of 1. You can see that most of the studies have shown an improvement as compared to the placebo in the C-peptide response, and the treatment effect at the year of year 1 is quite good in the positive range, and at the end of year 2 also you can see that compared to the placebo you have a better beta cell mass, and the treatment effect is also there. So there are still challenges there, that is because, as I already mentioned, identifying persons at risk in the absence of family history. It's not possible, because though we say that there is a significant component of HLA related and other genetic factors related things involved in development of type 1 diabetes, most of the diabetic patients whom we see, 90% of them, if you ask them, do they have family history? No, they don't have any family history. So identifying those patients for primary prevention is practically impossible. Even among those at risk, the time of secondary prevention is difficult to predict, because they may not actually develop. As I told you, antibody positivity, the risk of development is only 15%, one antibody positivity. When it becomes 2 antibody, it becomes 35 to 50%. Immunotherapy itself is not without risk. So when we cannot predict how much it is going to, when it is going to happen, it would be very difficult. So the window of prevention is again difficult, because you cannot give it very much beforehand. After some time, the beta cell is totally gone. So you need to catch them at the earliest phase when the beta cell damage has significantly rapidly progressing towards further damage. That window period is very short, and you have to target your interventions at that point. And also, the current therapy has not shown sustained benefit. So how much we can get benefit out of it from the combined therapy is something that has to be looked into as a next thing. So concluding, preventing or arresting type 1 diabetes remains a considerable global challenge. Promising advances are emerging. Teplizumab currently is the only drug which is approved by the FDA for preventing or delaying the onset of type 1 diabetes. Currently, there are many challenges to overcome. A reliable population-based screening program to identify at-risk individual is a major thing. Lack of benefit in some at-risk individuals with that therapies also should be looked into. Individuals need to take a fasting C-peptide level, and you have to look into the progression of that. Need for careful ongoing glucose monitoring, and last and most importantly, there is still lack of sustained arrest of the disease. Thank you. Thank you very much.
Thank you, Dr. Joe George, for a nice talk. Kindly take your seat with us. We will have the questions at the end of the session.
So our next session is on non-insulin therapies in type 1 diabetes, and for that I invite Dr. Mohan T. Sinoy. Dr. Mohan is a dear friend. He is a senior consultant endocrinologist from Trivandrum. He received Presidential Award of Appreciation in 2020 from Endocrine Society of India, have multiple publications, and is a member of the multiple societies. Over to you, Dr. Mohan.
Thank you, dear friends. Thank you, organizers, and thank you, dear chairpersons, for the kind introduction. This topic will be, again, we are a gray area, but we are going through very researches going on. So my topic is on non-insulin therapies other than what Dr. Joe and Dr. Shukla will discuss in type 1 diabetes management. No disclosures to make, because these are all investigational molecules and the upcoming molecules. I may be wrong in some times, but we'll have to accept that science is evolving, and we'll learn from each experiences only. So the outcomes, what I expect from the session would be that we understand that it is a challenging condition to manage type 1 diabetes, and endocrinologists are the best people suited to manage that, because it is a glucotoxicity, it's an ongoing inflammatory issues, and there are long-term issues also beyond pediatric age group. So non-insulin therapies carry the merits, demerits, and some results are there which are promising. And how can we impact this in real world? That we'll discuss in here. I'm grateful to Dr. Om Lakhani, Dr. Sri Nagesh, and Dr. Umesh Kumar Garg, who have given me time and they have given me efforts to help me in making my slides. So Dr. Joe has mentioned very clearly and categorically that it's very challenging to manage type 1 diabetes. Growing database research registries are showing India is coming up in a huge number. It may be overcome more than even China. So data in registry wise it's showing is increasing, and global prevalence, intensive insulin therapy is the only life-saving and very important thing, but there are some gaps which are existing, because they are not alone to manage in insulin alone, because some people have found that less than 50% achieve HbA1c even less than what we expect, because they have a long road to go. If you have HbA1c which is hovering around 11 and 12 for 10 years, it will definitely cause them cardiovascular impact or some issues. Previously, one of the questions was double diabetes. So that is adolescents with diabetes, they are going to have type 2-like features, insulin resistance. So doses will be more than 100 units per day. How can we do that in our patients with a population which is having difficulty to make what I call ends meet? So we need to have adjunct therapies beyond insulin. So rationale we'll discuss and evaluate the evidence and how to can select the patients which you are involved, and what are the risks involved, because don't go by what research says. No? We have risk with the patient sit in front of you, real world risk. You should say that what to say, we'll discuss that also. So I told you the average HbA1c in adults with type 1 diabetes published, it is 7.9%. That is globally. And India, it is more than 8.5%. 68% of them are having overweight, obesity. That is why we are telling this double diabetes. Cardiovascular disease is the first cause, highest cause in type 1 diabetes, not DKA. So DKA may kill, but the number we survive, they actually have cardiovascular disease itself. So catastrophe is diabetic ketoacidosis, but the mortality per se, it's because of the cardiovascular disease. That's why we are discussing hypoglycemia. Hypoglycemia can itself cause death, and weight gain, other things are also understood. So limitations of insulin therapy, this is just to hypothesize that the patient needs to undertake life, the pregnancy, the challenges of future, all these things going through, and the family, all these things, the time to eat, everything has to, whatever we say, sensor, pump, all therapies, the patient in front of you will have their own physiological and other needs, illness. So that's why insulin helps often, but sometimes weight gain, hypoglycemia, fear, the alpha cell overactivity or dysfunction, we know that excess glucagon, that actually is not addressed by any therapies which we are having in type 1. And that is why time in range, and our speaker told about insulin pump failure, all these things have to be accommodated. And insulin as such does not directly reduce the cardiovascular or renal risk directly. It's only through improved HbA1c. That is why we need to have quality of life also as a priority. So the mechanism, if anybody interested, you can see this picture very clearly showing you that I am discussing about 5 molecules as such: metformin, GLP-1 receptor agonist, then you have got SGLT2 inhibitors, you got pramlintide, and also some additional molecules like thiazolidinediones, and you have got bromocriptine or other older generation. So this targets show that there are different targets, mechanism of action, which is unique beyond insulin, and that is important in diabetes as such. So first is metformin. We have all been hearing about metformin used in diabetes. Type 1 diabetes also is useful as an insulin sensitizer in the people who are going to overweight. Studies were published, but there is no sustained HbA1c benefit, but there is a decrease in the carotid intermediate thickness. So it's best utilized in insulin-resistant type 1 diabetes and overweight individuals. HbA1c is very, very modest, only 0.3% in type 1 diabetes. Weight loss is up to 2 kg in long run, and insulin dose is also very modestly reduced. But limitations again, insulin, glucose, they have got GI intolerance and minimal impact in the long term. So landscape, you can see the medicines I have mentioned. The only FDA-approved medicine type 1 diabetes and non-insulin is pramlintide, but availability is not there in India. And I think it is twice or thrice you should do, just like insulin. It's also injectable again. And again, you have got investigation off-label use, because European it's on-label, but in India and US, it is SGLT2 inhibitors, GLP-1 are again off-label or only investigational use. They don't have correct indications to using. Limited evidence for metformin, DPP-4 inhibitors, thiazolidinediones, I mentioned. Emerging technologies are also there, like cell replacement therapies. Then smart insulins, they are also going to come up. And then immunomodulation, that's as previous speaker told. This is the current landscape of type 1 diabetes evolving in the future generation. So first is pramlintide. It's a FDA approved indication. Delayed gastric emptying, suppresses glucagon postprandially, also enhances satiety. Evidence shows HbA1c is 0.3 to 0.4 with modest weight, just like you have seen metformin. And the dose is like 15 to 60 micrograms subcutaneously before meals. It requires titration. That's important. So it's not a standalone or a single dose fits all. Key trials have been there, which shows a mealtime adjunct only. That means the person cannot take properly at time, the mealtime adjunct, just like a bolus-like requirement. So again, it does not do the basal work. It only has like a bolus. And this is a comparison where insulin plus pramlintide have been shown as a comparison. The dotted line shows, and the adjunct extra value showed by addition of pramlintide to insulin. So clinical application, best candidates suitable are, you identified them, you know the candidate phenotype, adequate basal control is achieved, only significant postpartum hypoglycemia is there, and willing to experiment or accept additional injections and seeking only modest benefits. Challenging is that, again, it's an injectable, GI side effects are again there, the cost not covered by insurance even abroad, not available in India as such, complex meal dosing calculation because each person behaves differently, and definitely once you start using them, you understand that dose of insulin comes down by at least 30 to 50% initially, and lowest dose can be titrated steadily. I don't have experience, I think that's only by literature they're showing it. It can consider in pre-meal anti-nausea medication if required. Next comes the SGLT2 inhibitors. So again, as you all know, its mechanism is renal glucosuria, and definitely it's got insulin, non-insulin mechanisms. Again, insulin independent mechanism if you know. And it's actually anti-apoptotic and actually a cell stress reduction. That is why you use even heart diseases. So cardiovascular mortality reduction in type 1 diabetes as an adjunct or co with insulin. There are so many studies been published in the last few years, but the risk is there, which is diabetic ketoacidosis, euglycemic ketoacidosis. That is what I mentioned here, dapagliflozin, empagliflozin, and even dual SGLT2 1 and 2, that is sotagliflozin, have been used. That is why this slide have been taken. This table summarizes whatever studies have been published in SGLT2 again. Sotagliflozin, I think 50 milligram is there, then 300 milligram is there. Advantage is once weekly, and you can see that empagliflozin also at 2.5, 10, 25, 100 they have used. Dapagliflozin again 5, 10, 20, 25 they have used. These are all showing that publications are coming up and data is promising. There are 3 landmark publications being published that I will show you. The first is DEPICT-1 trial, which shows 0.45% reduction HbA1c in 24-week RCT done in 833 type 1 diabetic individuals. They achieved 3.7 kilogram weight loss with significant compared to placebo. But again, they did not stop insulin. They were additionally continued. Insulin requirement in 13% is reduced. The number is also good. And there is 2% risk of DKA, diabetic ketoacidosis. So that is dapagliflozin versus placebo controlled arm. There is definitely an increased risk, but we can tell them you can do the ketone sticks measurement. It's well manageable, but the fear is always there with you. The tandem 3 publication with sotagliflozin, they did a tandem 3 to prove this efficacy. It improved the glycemic control, but increased the diabetic ketoacidosis risk. I won't again show every data here, but you can show that the number is good, promising, but again, DKA is again the reality there. So monitoring, how to advise them, I think very clearly the ADA has come up with a patient guidance. This is what ADA has told us. The initial assessment, evaluate risk factors progressing for diabetic ketoacidosis, teach them about sick day rule just like in type 1, whatever we do, tell them again and again, ketone bodies have to be checked, the glucose value may be still normal only, ketone monitoring, tell them frequently. So again, it is an algorithm-based approach, and it needs to be, because until stop SGLT2 whenever you are in doubt, go for only insulin that time. So again, insulin is the only thing which dose can be reduced, but again, frequent monitoring and time to treat them is also affected there. So best candidates are adults with type 1 diabetes and overweight obesity, no history of diabetic ketoacidosis, like well tolerated for a long time, reliable self-management skills. Can they cope with the issue of DKA? And can they access ketone monitoring? That's also another thing. And good understanding of technology, because that is also important. Some person not using it regularly, it's difficult to tell them that use this also. But I think a person motivated to do that, we can risk mitigation has been done. These are how we can do, even we can tell them about all these, give them guidance, give them leaflets. But again, what benefit do you get? Very minimal benefit, but long term, maybe they'll learn themselves how to manage it. So mechanism, I told you, it actually suppresses the glucagon and also central appetite, and this is the GLP-1 receptors, and definitely it's also requires the beta cell function. What happens in type 1? Beta cell, at least 90% is lost when you have diagnosed diabetes. So that time, already beta cell is worn out. So when you given GLP-1 receptors, maybe there is very minimal reserve only. So only in having a early onset diagnosed, like in preclinical, you can use that. But it is good for a well-motivated patient, again, just like in SGLT2. It reduces the post-meal, and also weight loss can be achieved. Clinically, it is not FDA approved except for off-label in clinical practice. European countries, it's actually having a label which can be given in a properly understood case. Best potential candidates are those with measurable C-peptide or recent onset type 1 and those struggling with weight gain on insulin. And practically, I think start slow and go slow. So that's what they mentioned. Very low doses, 0.6 milligram of liraglutide was used, and then I think newer generation semaglutide has also been used. So monitor the potential for ketosis and pancreatitis, because that is also a reality with this thing. GI side effects again give them slowly and monitor them. So evidence here, the adjunct 1 study, the liraglutide one, 52-week study RCT in type 1 diabetes having 1,400 patients, HbA1c again dose dependent, 0.2 to 0.4%, weight loss up to 1.5 kilograms, and 1.8 mg was the dose studied here, not the 3 milligram. Then increased symptomatic hypoglycemia was actually seen there, and dose dependent hyperglycemic ketosis. So again, we are just having the requirements. And it is showing LIRA-1 study also done in overweight type 1, this also similarly. GLP-1, it's good, adjunct and adjunct 1, adjunct 2 were studies with liraglutide, and exenatide, semaglutide also have done it. So definitely we need cardiovascular protection, and benefit is given, weight loss also there, insulin dose up to 19%, 20% dose can be reduced, HbA1c up to 0.7% versus placebo. So finally, last 5 minutes on what meta-analysis has taught us in this. I just searched the data. 57 RCTs were published, including more than 5,000 patients in real world. And HbA1c studied on real world came to 0.3% reduction versus placebo. Weight loss on average of 2.1 kilogram. Insulin dose on average of 5 units per day. Results were, I think, hypoglycemia and GI upset were there. Diabetic ketosis was also captured in a good number. So trials I have shown like almost similar good result. That is why we should understand before starting to prescribe. GLP-1, that is the semaglutide weekly, is also coming up big time, and I think type 1 studies are going to come with cardiorenal outcomes also. Exenatide already has data with postprandial control. Dulaglutide established with type 1 diabetes, limited studies are there. For future, definitely we are seeing more and more molecules coming up in this area. So DEPICT-1 study, SGLT2 definitely is in a showed, I told you the numbers and all. 5 milligram, 10 milligram dapagliflozin was studied in that. Tandem studies, sotagliflozin showed you a result of 0.46 only, DKA risk of 2.3%. And actually it showed a better outcomes in non-pump users. That means a patient early telling them properly, it actually favored the people not using the pump. That means they can be monitored themselves. Another program called EASE program done with empagliflozin published showing 1,200 patient type 1 diabetes, showed a very good result. Again, HbA1c reduction, but no increase in DKA, but that is actually used in patients using closed loop system, that is insulin pump system, and it is found to be coming up in an efficacy manner. Pramlintide evidence, I think FDA approved since 2005, that is 20 years down before itself, and HbA1c reduction of 0.3, weight loss up to 1.2, 1 to 2, and limitations, nausea, multiple daily injections. And last a few slides about DPP-4 inhibitors. Some patients have studies on type 1 diabetes, sitagliptin, saxagliptin, linagliptin. Minimal HbA1c benefit just as like a placebo they're giving, and is well tolerated but not effective. So it's not recommended in type 1 diabetes as such, and will minimal HbA1c. Thiazolidines, again studies were there initially, but again not futuristic, so it's just coming out of the way. Bromocriptine was the first FDA approved molecule in India, so there is only one short RCT, again only minimal, more trials available, which I think we do. Then dual tirzepatide, cagrilintide actually going up, but I think again understanding type 1 diabetes requires insulin, we have to see more data to be sure about it. So last, summarizing my talk today, we have got so many molecules in the available like metformin, GLP-1RA, SGLT2 inhibitors, pramlintide not available in India but abroad. So if you're telling them that this is the data which we have, which is definitely very interesting, we can tell patients there is a hope on the way. In future, maybe another speaker 2 years down the line may be telling it's already there. So I think we have to see more and more data published. And we should have patient-centered approach, because whatever said and done, the patient should be in center of the discussion and tell them that weight loss, post-meal excursions, insulin resistance, all these things can be handled, but we have to hold their hands. Then only we can, psychology support is required. Evidence is definitely, I have shown you, grade B evidence with pramlintide, and similar with SGLT2 and GLP-1, and grade C evidence with metformin. So it's definitely showing a very clear what is available. Practically, we should tell them and motivate them, adjust the insulin, don't stop insulin any time, and use CGM and ketone monitoring additionally to help you get the best outcomes. So I think we are getting more and more data coming up. So definitely precision medicine is going to be very useful, and how these pumps also will integrate them, it's coming to be interesting. Emerging therapies like stem cells, which I think the next speaker will tell you, definitely it's going to be the path breaker. I think some patients already coming up with some evidence on insulin independence is gone, but again, I don't want to tell that here, but we should again see whether immunosensitive and all. So limited duration of transplanted cells also is there, cost is very high. So I think if you have got centers doing it, definitely it's quite useful, stem cell transplant. So takeaways, again, definitely understand that only FDA approved is pramlintide. Non-insulin therapies are challenging with limitations. SGLT2 are very good, but again, DKA risk is realistic. Select the patient, develop your own protocols, and then your patient bank, you tell them what to do. And consider prevention protocols at the first time, DKA prevention protocols. And stay informed, go for the trials, whatever published. I think we all check the PubMed and all. We just 10 times will come. Again, therapies are emerging. We'll definitely wait for more time to know more. Thank you very much. I think I'm open to questions.
Thank you, Dr. Mohan, for the nice talk. Please join us here. The last talk of this session is on beta cell replacement in type 1 diabetes, advances and obstacles. For this, we have Dr. Ravindra Shukla. Dr. Ravindra Shukla is additional professor in the Department of Endocrinology and Metabolism at AIIMS, Jodhpur. He has close to 40 publications. Dr. Ravindra, the stage is all yours.
Okay, thank you. I would like to thank the organizer for inviting me on a topic which I've been working for 7 years. It's especially memorable to be in front of your teachers. I hope I meet your expectations. I cannot use this. I hope you have got the slides, right? So my talk is going to, I think Dr. Mohan told about the futuristic therapy, the cell therapies. So he told it's emerging therapies, that it's not true, because there are at least 28 individuals, type 1 diabetes individuals in the world, in this planet, who are living without any insulin for at least 2 years minimum. So it's there. The therapy is there. It involves very high. After the peptide molecules, it's a different level of manufacturing and technology development. So those are its drawbacks of pitfalls. I'll be discussing data from most last 1 year, which is been published from NEGM. I think 2 articles in NEGM, one in Nature, 2022 article, one in Lancet, which was a long-term Islet outcome article, which was very important. That's why it published in Lancet. Are you having problem with PPT? Yes. So I think I can just start the presentation, without the PPT itself. So so when we talk about the cell replacement therapy, should I give you time, or I can start my presentation? No, but filing. Yeah, this is my CV. This is not the PowerPoint presentation. Yeah, this is CV. What you've got at my CV. I mailed it 3 days back. Sorry.
So in the meantime, since he's taking some time, we can invite some questions for the first 2 speakers if anybody wants to ask.
There is one thing I really left out. I oversaid. Thank you. I think one of our important things is AGI. But again, I think just like others only, it's not having much benefit in type 1 diabetes. But I think adolescents who are going into adulthood, 25 to 50 mg can be used. Realistically, Indian patients tolerate much better than the other study. I'm agree. I'm sorry. Yes, correct. So type 1 diabetes, AGI, alpha-glucosidase like voglibose or acarbose can be used. But again, the same thing issues are there. Thank you.
AK Singh, sir, please. Yeah.
audible?
Yes, sir.
Mohan, thank you. I think we need some clear message. We have presented various data on SGLT2, GLP-1. The moral of the story is we are not licensed to use any of the drug, be it SGLT2, GLP-1, DPP-4, acarbose, TGD. Answer is none. So the message should be very clear. Let me make an abstract of what you presented. SGLT2 has been tested in many trials, as you have shown. At least there are 10 RCTs done with SGLT2. In 2019, only European Medical Agency gave license to dapagliflozin 5 milligram and sotagliflozin 400 milligram in adult type 1 diabetes whose BMI was more than 21. In 27. In 2021, even EMA took off that license. So neither US FDA given approval to SGLT2, nor UK MHRA given. EMA given it in 2019. In 2021, both AstraZeneca and Sanofi withdrawn their approval by themselves because of the lawsuit issue. At the moment, only the Japanese PMDA allows dapagliflozin and ipragliflozin in Japan. In India, we don't have license, so we cannot use it. With regards to the GLP-1 RA, as you shown adjunct 1, adjunct 2, there is one trial with exenatide called Extend. They did reduce HbA1c, but that was such a small HbA1c reduction that none of the regulators has ever given approval to GLP-1. DPP-4 doesn't work at all in type 1 diabetes, so not licensed. Acarbose and all those ancillary treatment, including metformin, nothing is recommended in type 1 diabetes. So all discussion rounds to only theoretical. We are not licensed to use any drug. That message I wanted to give it to the audience.
Thank you, sir.
Insulin is the only approved therapy for type 1. Other than that, we definitely have to get more evidence.
One question regarding this aspect, initially to my speaker and then sir can inquire. In type 1 diabetes, long duration who has developed diabetic kidney disease with albuminuria, the usage of SGLT2 inhibitors in this group of patients.
Okay, so trials are currently undergoing. There are 2 trials with SGLT2 currently being done in people with type 1 diabetes with kidney disease. The result is not out, so we don't have license.
One question I have, maybe Mohan or sir can answer. What about the use of the metformin in type 1 diabetes when they are adults and the weight is on higher side? Means there are features of insulin resistance.
Definitely, I have told that it's there. The number of patients may be coming up, but definitely it's, again, as I told, it's useful, limited indications only. Lactic acidosis and all those things are there. Vitamin B12 deficiency we can tell, but ultimately the patient's dose is only reduced. That is the only thing. We don't have anything additionally achieved. But in adolescent patients, obesity, PCO like patients, they have a definitely insulin resistance. They can reduce the dose. But definitely it's only a way in which we portray it, not very, and 500 mg, 100,000 mg, not very high doses.
I would like to support sir and also the nice talk by Mohan. Here one thing we should understand is that the FDA criteria for accepting a drug as a oral or any anti-diabetic agent, the average A1C reduction that is provided in that particular condition should be minimum of 0.4 of A1C reduction. That should be documented in more than one clinical trial. So if you can see from the Mohan slides itself, most of them the average A1C reduction was only 0.3 or sometimes 0.5 and all those things. So none of them actually qualified to be classified as a drug that can reduce. And again with the metformin also. But what I personally feel is that in the previous session also there was discussion by Madhu sir about dual diabetes. Because nowadays, see, if you ask me, we cannot generalize and say that metformin is effective, DPP-4 is effective, or this thing. But there are definitely a few cases like this as a very obese person or with significant insulin resistance. I do see, those are not norms or guidelines or anything, but if you take that selective group, I have tried metformin with very good effect in those very obese type 1 diabetics where the insulin dose has significantly come down That is, sir, what is your take on those aspects? Individualized case.
Yeah, so I agree with you. Surprisingly, SGLT2 should have lowered HbA1c effectively. SGLT2 inhibitor doesn't need beta cell to work. So if patients with type 1 diabetes on SGLT2, the HbA1c lowering was effective in some trial, but it was inconsistent. As you said, it varied up to 0.5, 0.7 in some of the trial. So SGLT2 theoretically should work in people with type 1 diabetes. The US FDA did not give the approval because of the risk of DKA. The DKA went to 10% in one of the trial, in each 3 trial. So there are, as I said, there are 10 trials of SGLT2 in type 1 diabetes. So what was surprising to note that SGLT2 should have been worked in people with type 1 diabetes, knowing well that kidney is intact and SGLT2 receptor is fine. But surprisingly, the SGLT2's HbA1c lowering was not consistent. Contrarily, the GLP-1 receptor agonist was not that effective, because for that you need beta cell. In type 1 diabetes, it is obvious that DPP4 and GLP-1 would not work because you don't have beta cell. And therefore, the US FDA never ever approved GLP-1 or DPP4 for type 1 diabetes. Now, let me tell you, this year at EASD, which concluded very recently, the semaglutide 2.4 milligram has been tested in people with type 1 diabetes with a BMI more than 27 and 30, means obesity. And semaglutide 2.4 milligram was pretty effective. So that was published in NEJM. So, but there is a long way to go for the
So that was a just type 1 diabetes trial that you're talking about?
Yes.
And theoretically, the glycemic variability should be minimized with the use of the SGLT2 inhibitor. So maybe the HbA1c may not be coming down, but the variability may be reduced.
Dr. Shukla, are you? The slides are fine.
Yes.
Okay.
Thank you.
Okay, we can continue with the talk.
With the way the slides were lost and now they're found. So the concept of beta cell replacement is based on a broad concept, which is that of a cure-based therapy. So it's an emerging field of anti-aging medicine as well as the regenerative medicine. What is aim of cure is to actually reverse, suppose somebody is having CKD. So instead of, either we can transplant a new kidney, which is not that effective, but actually to heal kidney to the back to a normal healthy individual. So and type 1 diabetes has become the first disease to be cured by this thing, and first disease, first non-communicable disease to do that. Although there are a lot of improvements which are going to happen in the cell therapy future. So here, before I begin my presentation, actually, since there was a lot of basic science involved, I thought I should put some of the clinics here. So this is for a joke. I've put it here. You see the forest diagram. I compiled all the studies of type 1 diabetes on insulin pump and on non-insulin pump, all your glargine and all those stuff. So see the mean difference in TIR. So hazard ratio is like 10 to 15. So even the pump is like 15 times better than any of the insulin regimen, yet pump has only a TIR of 65%. That was the average I got, at 65 to 80%, the range. So this shows, and in type 1, type 2, it's very easy to get that TIR. So even the best pump, 65% to 80% what you're looking at. A flow chart of that. So just I would like to concentrate on the last 1 year. So the milestone, these are the type 1 diabetes milestones, 2 of them, the discovery of insulin as well as the radioimmunoassay, they got the Nobel Prize. Last 1 year, you see, there's at least 3 or 4 milestones which I'll discuss them in future slides. So what is the indication? I think there was a lot of talk about the brittle diabetes and also Dr. Madhu's data that the type 1 diabetes patients are very difficult to control. A lot of them, they end up in having complications. So the indications is any of the brittle diabetes, which is defined as hypoglycemic awareness refractory to medical management. So that's where all the cell therapies are being given. So they're not being given, for example, in all type 1 diabetes or all diabetes patients, but in future, they would be given like that. Total pancreatectomy is one of the reasons when you remove the pancreas because of pancreatitis. So you can isolate the cell and transplant that. That's also an example of cell therapy being there worldwide for more than 20 years. If an islet transplant fails, so those are the patients who were recruited for the forward trial, and also that one patient who was the first cure in China. So failed islet transplant is an indication for that. If islet is not available, then we do go for a pancreas transplant. Just so these are the types. So pancreas is available in India. Islet is available worldwide since more than decades, I would say. Xenotransplantation is actually taking cells from the genetically edited pigs or monkeys and then transplant them to humans. So this for all the transplantations. Including Kolkata, somebody has transplanted the long back, in 40 years back, I think, from a pig liver in a heart in a patient, and the patient survived for 13 days. So this was a field which was, kind of scuttled because of many reasons. I won't discuss that. Then last three, the stem cell derived beta cells. At present, they are with immunosuppression, but future will have that without immunosuppression. There's also one case report last week published in NEJM by Oli Korsegren's group. So I'll discuss that. I could not read that, but I have personal communication, so I'll give some of the things. So I'll just cover this briefly. The pancreas transplant is when you transplant a pancreas, there are actually two pancreas. You don't take out the pancreas. So, and when you transplant a third pancreas, it's also inside the body. It's so cumbersome that it should not exist. So worldwide, nobody is transplanting pancreas. It has decreased by 50% in the United States alone. It leads to major changes in gastric anatomy. So islet transplant, which is the next one, so which it has largely replaced the pancreas transplant in brittle diabetes. So again, not much of it. So what we do is we take out the pancreas, we isolate the islets and then put it inside the liver. Liver is the only site where all the cell therapies will be done in next 5-6 years. Although we have with islet transplant, we have experience of putting the rectus abdominis sheath inside the eye, inside the testes also, everywhere. What I've showed in the CGM is a patient on Medtronic 780 pump. You see the fluctuations with the pump. Algorithms are only good for the way they are only good to have, they are not God at present at least. So you see the fluctuations there, and after islet transplant, the pump is removed. That's great. So this is very few patients have got that. So to me, seeing the patients across the world, the patients were unanimous. They would throw away the pump for a islet transplant, and that would same be hold true for the cell therapies. Pumps are nowhere. I mean, that's what. Why long-term data about islet transplant will give way to the stem cell derived therapy, but the lessons which we have learned from islet transplant, seeing the patients. So there have been like 4 of the centers around the world, the United States, University of Alberta, and the Toronto General Hospital Network. Gradual Network is for the Central European countries. I've been to all of these 4 places. They have a pretty much good data, and I'll discuss the Lancet data, which was published by Professor Shapiro's team about what happens when you give. So what happens to insulin independence? A lot of people say there's only 50% chance of insulin independence. But the fact is, if insulin independence is there for first 2 weeks, it's likely to persist for 20 years. So 20 years without insulin. Though for it works, this treatment works, it's a kind of a godsend thing, without being on any insulin and having an A1C of 6 to 7. So that is something which needs to be, that's what we got to know from the 20 years data. This was in 2022, it was published. Now this is data I got it from the Mayo Rochester, where I was there last year, and also the University of Minnesota cohort. So the red dots are those patients who waitlisted for transplant, could not get it. The blue ones are the ones who got the transplant and got rejected. So basically both of them, they are not having any cell therapy, should not have any cell therapy effect, because the transplant has been lost. But over 200 months, which is like over maybe like 15 years, those who see the red dots, they're having an A1C which is less than 6. With just subcutaneous insulin, many of them are pumped. Actually, most of them, they are on pumps. That's okay. But you see, compare them with the red dots. So this works even when the graft fails, which is something which will come up in the research in future. It's probably because there's some cells which secrete some unknown hormone which is not known, and they work in the glycemic control. So that could be reason for this. Nephropathy, you see, it plateaus. So we have a lot of data about ARBs and all that. But to have, EGFR being stabilized for 20 years, that's again from the Edmonton data. That's a big thing. That's like, but I know there's a cherry picking. There are limitations. Immunosuppression. The patient has to be immunosuppression, should be clinically wise enough. And the previous speaker talked about teplizumab. Why teplizumab is not being given in India? The reason, even in US, the problem is endocrinologists don't have, experience of doing immunosuppression, which is very important. We can even do with the ATG also. Teplizumab is not needed. We can reverse diabetes. One patient I tried in 2018, just give ATG. So it's about having experience with immunosuppression, and then, so it's not that only teplizumab is available. It's about the clinical skills with immunosuppression. We should all focus on that. Then there's poor engraftment, the liver graft fails, the islet graft fails, that's a problem. And then there's important thing with the quality of the islets, which is, when we do the procedure, we isolate the islets, that's a problem. The mitigation strategies, a lot of them, we can get alternative source of islet, and then I'll come to the stem cell. So stem cell are the alternative source of islet. Stem cell is going to replace the source of islets, donor islets, cadaveric islets in future. Maybe that future is not like 10 years. We'll discuss a forward trial, which is published in NEGM this 2 months back. And in China, I have personal communication. They will not publish the RCT, but their patient is doing even better than what we got in this. So a bit on now the basic biology. So there's PSC stand for pluripotent stem cells. So these are the cells which can become any organ. So that's what they are. CIPSC stand for the chemically induced pluripotent. This is a very different technology, only in by Deng, Hawking Deng. In Fudan University, China, they've got it. iPSC was discovered in Japan, and then all of the therapies we were discussing are derived from the iPSC. Then genetically edited islets and hypoimmune, these stem cells are the ones who are like, the autoimmunity cannot attack them. So those are the hypoimmune islets, which is again, in a research, there's no publication. Genetically edited islets, I'll cover some of it. So we have like 3 things in the stem cell which I'm going to cover. So just brief on the person who got the induction of the pluripotent cells from mouse to embryonic adult fibroblast was Yamanaka, and that's how we can make stem cell from any of this, and that was in 2006. He got the Nobel Prize in 2013. This was the fastest medicine Nobel. In 2006 there was discovery. It generally takes decades to get a Nobel Prize, but this was such a revolutionizing technology. And then after the COVID, what people did not know, there was in Nature, there's this article by Hongkong Deng's lab in Shanghai. This was funded by the People's Liberation Army. All of them, they are those from China. So what they got is they got a chemical repopulating problem, which means that my finger can become pancreas, and then again it can become finger in one day. That's the technology they have demonstrated, which is, so 2 types of cells we have, and which is for the ethical problems, okay? If you convert my finger to kidney for a day, and then again but there are some animals which do that, and they have demonstrated this. So there's a difference between that. The CIPSCs are the newer ones. They require longer culture. They require a lot of things which are not published. They don't publish these things. iPSCs, that's what the NEGM article is about, which I'll cover. This is the protocol. There are a lot of things in it, but we should keep in mind that we can start with CIPSC, or we can start with the iPSC from here, and then it can differentiate into different cancers as well. So that is a problem with stage 5 and above. So when you transplant stage 5 and above, there's chances that they become a teratoma. So that was a thing which was holding back the cell therapy, and that we have got some technology because of we can prevent that, and that's how it's been done in humans now. So this was the 20th June in ADA. It was presented, and same day it was published in the NEGM. So it was peer review or done, I guess, in a 1 hour or 2 hour, I guess. So that was the fastest peer review. So this was there were 14 patients, 2 patients died, 12 patients were without insulin for 1 year, more than a year. And if you see the insulin requirement, they become 0 actually. A lot of patients were actually taking insulin just because their family members were telling you'll get ketosis. I know 2 of the patients who were in Mayo. So it was fundamentally working very well. The therapy works very well. And if you see the time in range, so it's like 90%. None of the pump can ever achieve. That's a challenge. If you show this 90% from Medtronic 780 pump, it's not possible to have that. And there is absolutely 0% hypoglycemia. So hypoglycemia is eradicated. And the A1C was, you can read 5.5 to 6, something in that range. But 2 patients died. So this was an article before that. Last year it was published in October. Because this article was published from China, that about 1 patient, see, it's 100%. 100%. That patient is having 100% time in range, which all of us in the here. So this is what we are talking about, the anti-aging therapy, and we're also talking about the cure-based therapy, which is the future. Because of them, the Vertex technology had to publish the NEGM article. Otherwise, they would not have. There's so much of money going into the GLP-1 and the newer pipelines that this cell therapy would not have. That's why I'm very thankful to Shusen Wang and as well as Hongkui Deng. Shusen Wang was in Chicago for more than 20 years when during COVID he went back to China. CIBSC is not available for outside non-Chinese nationals. It will be available to BRI countries, but never to the Western countries. So this is a technology which and we are mostly going to get the finished product, not the technology. That should be okay. So now this is a very difficult part. So when you talk about the quality control and the FDA approval, whenever you prescribe a cell therapy, what are the things you have to see? Whether it works the same, which means it should work, release the insulin in this case. Whether it thinks the same, which means that it should have the genetic chromatin signature, which are like beta cell. It should not have genetic signature, for example, of insulinoma, but then it becomes a tumor and then it's a problem. So, and whether it looks the same, which means when you see in the slides, they should be arranged in a particular manner in which we see the normal islets. And whether it stays the same, it should not become, go where and become a malignant cell. So these are the things in future when we'll be prescribing, and it might be in 5 years when we'll have the product to prescribe. Even we can have our own indigenous Indian, that would be even better if we have that. What future they're doing is that it's possible to genetically edit the cells. There was a heart transplantation which did with the pig genetically edited, so it's possible with the islets. And being there of publication with that, but not in humans. So then the cells can be encapsulated, because when you put the cells inside the body still thinks it's a foreign cells and attacks it and try to destroy it. In type 1 diabetes, autoimmunity itself tries to destroy the cells. So those are things encapsulation we can do, and there's a mass production. So all of these, for example, that 12 patients who got cured, there was a lab of at least 6 labs and around 150 people working for 5 years, and then they got these results. So there is a scope for mass production, so which means automation and robots. Then only it will be available for the market for everybody, because it's very costly at present. It's just a technology demonstration rather than treatment. So this was the project I was working on. So we were editing the embryos, the pig embryos, and putting them inside the monkeys. So for one species to another species, if you can make the graft survive, you can actually, do that. So, but this is not the future. Is, I say, still it's a stem cell derived beta cells. This product, because you'll need to raise pigs in germ-free environment to kill them, to take out this a big thing. So that's not going to, it's not going to be there. But I was just like, it is xenotransplantation. I thought I should put a slide. Now this is from Kalinska, mostly based out of Uppsala University and Scandinavia. So I was in contact with Cole Sigrin. He was not in favor of publishing it, but the Sana technology wanted to publish it. NEGM editor wanted to publish that. That's what it was published. This was published last month, so I have not read this article. What I know about this patient is that they use this fused images of MRI and externatide PET to image the cells. So this is the first time an MRI has been used to image the cells. Like image cells have never been imaged to that microscopic level. So I was mostly fascinated by this PET MRI and externatide combined tech, which and this is patented in Kalinska, I guess, in Sweden itself. This patient, they edited the islets when they put it inside the patient without immunosuppression. So this was somebody else's organ which is inside. That only happens in pregnancy, and because of this, another reason why it happens only in pregnancy. They have demonstrated. Again, this is something very new. This was in August, like in last month it was published. So this ends my presentation. So I've been working on this field. I've been worked in almost across the Atlantic and all the major centers. So this is a photo I took outside my lab. So when you stain the islets, the green is the alpha cells and the red is the beta cells. So you want that more and more, beta cells, the red, and that's what just the change of color in the tree. I think if you could have someday, those things, you could change the cells population into different things. So this ends my presentation. Thank you.
Thank you, Dr. Shukla. And it was really interesting, and in fact, optimistic lecture about the type 1 diabetes. Now, we are already running half an hour late, so we can have only 2 questions.
Yes. It's in NEGM August 4, I guess, got online. Yes. Okay, so what we do is that we take the islets of the donor and we put the HLA same as the recipient. So it's possible with the genetic patient, and we silence its own HLA. With the again, it's possible with the use of guide RNAs. So can be done, but this was demonstrated. It's theoretically it's very easy. Yeah. Yes. Yes. So HLA A1 mostly we do A1 HLA A B C. So we mostly match HLA A1 and A2 in case of islets. In case of renal transplant, we mostly I think do the HLA C, I guess, but I'm not into renal. So those are the important. Yeah, in this it was there, but there are a lot of things. Okay, it did not work for 2 patients. It worked for this. How it has worked, so they are not disclosed. It's very difficult to silence HLAs in any cell. That's it's very difficult. If you could.
Professor Passes.
My question first to Dr. Joe. What is the current status of GAD vaccine, which was once time very much popularized? GAD vaccine and nicotinamide trial, that was a very fascinating trial in the past.
So in my slides I had presented it. Only thing is that I didn't present the presentation, but in the last but once before the conclusion I had presented one data which included what is the benefit of each one. So initially they showed some benefit, but overall when you look at it, it doesn't look to be promising. In that slide it was there actually in the figure, the GAD alum being used and nicotinamide being used. So those studies didn't show that much future of going into, because silencing the antigen was not found to. See, initially some response was there, not long. It's not there.
So down the line, these GAD and nicotinamide is going to oblivion now.
So science you can never say like that, but currently it doesn't seem to be having a very bright future in that.
And regarding Shukla, thank you very much for a very fascinating and stimulating lecture. We had the conception that diabetes was sort of express highway without any U-turn, but a new horizon has opened up. So I think the whole procedure is very costly, and in India it is a nightmare. Let us hope for the future, because some silver lining in the darkness and light at the end of the tunnel. So thank you very much as your teacher.
Thank you very much for your comments, sir. Because we are running out shortage of time, I cannot allow any further questions. I thank all the speakers for doing a wonderful job in a very difficult topic. I also thank Dr. A.K. Singh, sir, for your valuable and inputs. It added value to the discussion. Thank you everyone.
So now we will have the last session, the metabolic health beyond the basics. For the session, I would like to invite Dr. Sandeep Kumar Shahu sir and Dr. Jan Ahmed sir on the dais as the chairperson. And one thing to note that Dr. Usha Sriram is not available. She is not available due to her illness. In absence of her, we will play a video regarding the topic at the last of the last session.
Good afternoon all. So we'll start the next topic, that is the metabolic health. So to start the first topic, that is the pitfalls in HbA1c level, we'll have our can show this. So our first speaker is Dr. Ravi Kumar Padala sir. He is a professor and HOD at MKCG Medical College in Berhampur and chief endocrinologist at RK Diabetes and Endocrine Center at Berhampur. Has a number of publications, organizing chairman in .con 2K25, organizing secretary in ISOCON 2K19, and there have number of publications. And welcome you sir. Thank you.
Thank you, chairpersons. Thank you, organizers, for inviting me to speak on a topic that usually we don't speak much because we are using this as a day-to-day our practices. And from type 1 diabetes, from the fantasy world, a beautiful fantasy world, we saw that 3 beautiful talks. And from there, I have to bring it to back to A1C, the real field where every day we deal with the patients. So, HbA1c as a diagnostic measure, ADA has said in 2009 it has been approved as a diagnostic modality, for diagnosis of diabetes. And for the control of diabetes, we have been using it since the trials of DCCT and the EDIC trials, and then followed by UKPDS. We have been using this for a long time. But there are certain things which we must know how to interpret A1C and in various conditions. So what is A1C? A1C is nothing but a non-enzymatic glycation of N-terminal valine of beta chains of hemoglobin. Now it is the irreversible hemodory formation that is we are measuring, not the reversible skip base that we are not measuring. And it represents average glycemia over a past 2 to 3 months. And there is another term known as the total glycated hemoglobin, which is A1C plus glucose that is being bound to lysine in the beta chains. Many people doesn't know that there is also glucose binds to the lysine in the beta chains at multiple other sites. So that is also known as, that is known as the total glycated hemoglobin. So what contributes to A1C? 50% is from the preceding 1 month, 40% from the preceding 2nd month, and nearly 10% from the preceding 3rd month. So nearly 90% of A1C is being contributed by the past 2 months glycemia. Now there are many advantages, we all know this. We were studying this and we were doing some of the studies while I was at PGI. So at that time, it was 2008 and 9 at that time, still that A1C was not being approved as a diagnostic method at that time. We found that, as we know that A1C doesn't require any fasting states. And the main advantage is the biological variability is less than 2% when you compare with fasting plasma glucose, which is roughly 7%, and OGTT glucose is roughly 12%. The pre-analytical variability is less compared to glucose estimations. You know that nearly 3 to 8 milligram per deciliter per hour, there can be decrease if you are analyzing the blood for the glucose estimations. And it is a very well standardized by NGSP2 DCCT trials, and it is related to diabetic complications, both micro and macro complications following the DCCT and UKPDS. But there are certain limitations. One main important factor is it depends upon the erythrocyte turnover rate. So any condition that is likely to increase erythrocyte turnover or decrease the erythrocyte turnover, there are multiple reasons. I don't want to read about those things. So there are multiple reasons where there can be increased erythrocyte turnover or there can be decreased. Hemoglobin variants, we will see that in subsequent slides. Hemoglobin variants has been one of the important factors while interpreting the A1C. Neonatal diabetes mellitus. HbA1c hemoglobin F is the major hemoglobin that is there in the neonates. Even up to 50 to 90% there can be hemoglobin F. And A1C cannot be useful in those conditions. Similarly, glycemic variability, it cannot capture glycemic variability, and in a fulminant diabetes, it cannot also capture. The one more other condition is the cystic fibrosis related diabetes. It is also not a useful measure. Now, some basics about hemoglobin. You see, hemoglobin is generally we divide it to hemoglobin A or the adult hemoglobin, A2, F, and variants. And hemoglobin A is again A0 or A1, A1 again A1A, A1B, and A1C. So what we are measuring is A1C, that's what we are measuring. But basically, A1 is fructose that is bind 1,6-diphosphate that is binds to the glucose hemoglobin, and A2 is glucose 6-phosphate, and A1C is the only direct glucose attachment to the N-terminal valine of the beta chains. So what we are seeing is A1C is the only one which directly glucose binding to the beta chains of A1C. That's what we are measuring. Now, these are the various methods of estimation of A1C. We all know this. There are 5 methods. The important thing is that the HPLC method, which depends upon the ion exchange, and capillary electrophoresis that also depends upon ion exchange. And IFCC says that capillary electrophoresis is the main standard basis on which all others are defined. Although we say that HPLC is the standard when we are comparing with the NGSP2 DCCT trial, that we are, because that is mostly accepted because that has been validated in various clinical trials. And there are also boronate affinity and various enzymatic methods. These are the various methods that are there. Now, generally when we read a HPLC reports, or we don't see the graphs actually. So that is where it is very important to see the graphs. You see the first peak, that is A1A, second peak A1B, then it comes the hemoglobin F, then comes the A1C, then comes one more that is known as the P3, and then comes the A0, then comes the variants. So how these things are important? Yes, these things are important. Because many times what we see is that the P3 is the degraded hemoglobin, and it should be less than 10%. Suppose if it is more than 10%, probably you should not read that. And also one should be very careful while reading A1C reports, because the area under the curve also you should see what is the prescribed by the area under the curve. So I will not go into details much about it. These are the various conditions where it can be affected, it can be increased, like conditions in which erythropoiesis is affected, glycation conditions like alcohol, chronic renal failure. These are the various conditions. And RBC destruction when it is increased or there is interference with A1C SS. That is very important, especially in hyperbilirubinemic conditions, lipemia, alcohol. There are various conditions which will affect the A1C. Now, what pitfalls we have to looking at it is, one is age, second is ethnicity, various hemoglobinopathies, CKD, CLD, pregnancy, drugs. You see the A1C with the age, we all know in clinical practice that A1C increases with age. But is there any cutoff to diagnose or the control measure in the elderly people? We don't. Because this is the study which we have published in 2011, where we found that alteration in A1C with age from the Chandigarh Urban Diabetes Study, we found that above the age of 20 years, there is increase in A1C at the rate of 0.01% per year. And interestingly, you find that, and this is independent of glycemia and BMI, even in normal people. And more than 50 years of the age, you find that more than 6.5% will be observed in 6.5 people of normal people. So how can you apply A1C in a people above the age of 50 or 60 years? And the 95th centile in the study was found to be above the age of 70 years was 6.5. So at least people above the age of 65 or 70, probably you cannot use 6.5 as the diagnosis or for the control. Now this is another study where in 2019 it has been published. 2 cohorts of people were followed, and it has been seen that both men and women, you find that as the age increases from 20 to 39 years, you find that above the age of 60 years, you find that the A1C levels go on increasing. And interestingly, the 97.5th centile, you can see that in the age group of more than 60 years, it is 6.5 and 6.6. Meaning by that above the age of 60 years, probably it is one of the pitfalls. I think future, probably there are more studies or more data once it comes, probably people will think about it more seriously. Now, the other question about the ethnicity. Is there any difference in the ethnicity? Obviously, there is a difference in the ethnicity because one of the meta-analysis of 12 studies of nearly 48,000 people, and it has been seen that nearly the blacks have 0.26% more, and the compared to Caucasians, Asians have 0.24%, and in Latinos have 0.08% more than Caucasians. So this means because there is a glycation process in the ethnicities for a similar glycemia, it differs. Therefore, we cannot apply. Now coming to the hemoglobin variants. Now this is one of the topics where nearly very important because 7% of the world population is having hemoglobin variants. And the SCED are the commonest variants that are available. Suppose in a homozygous state, somebody is having SS or CC or DD. In those conditions, obviously you cannot apply HbA1c because they are homozygous state where hemolysis will be occurring and you cannot use it. But in a heterozygous state, it can interfere in the analysis of your A1c by various methods. So, when do we suspect a variant? When A1c is much higher than what you expect or more than 15%, you should always be careful. And A1c value does not correlate with your SMBG. And A1c value is radically different from a previous A1c result following a change in laboratory where you are seeing this. So these are the conditions in which you must strongly suspect. Now, various methods can be affected with this, and one of the methods is the immunoassay. What is happening is the immunoassay is that there is antibodies are used against the beta chains between the 4 to 10 amino acids of the first 4 to 10 amino acids. So because hemoglobin S and C, the mutation is there at the 6th position of the beta chain. So that is the reason why immunoassays might be get affected. Whereas biorad machines, if you see that mostly SCED they are not getting affected, and there is various variants have also come, probably they are not getting affected where you have some doubt. Boronate affinity method probably seems to be a better alternative. Now iron deficiency anemia. We have been reading in the literature that iron deficiency increases A1c. And there are various explanations, various methods have been told. And one of the trials has shown that nearly 60 people were compared with euglycemic iron deficiency anemia with 60 people euglycemic without anemia. And what they found is there is an inverse correlation between hemoglobin, iron, serum ferritin. And if your serum ferritin levels comes down, the chances of becoming a pre-diabetic A1c, even in a normal people, is 1.87. Odds risk is 1.87. So one should be careful while reading the in iron deficiency anemia. Now this is a study by Madhusar et al. And this has been published. While comparing the iron deficiency anemia and the normal people, the A1c difference was 5.5 in iron deficiency anemia and 4.9, meaning there is a 0.6% difference in the iron deficiency, it is causing increased. And once you supplement with the iron, it has been seen that from 5.5 it has come down to 5. So therefore, iron supplementation in iron deficiency anemia, probably it is also affecting the changes. Now what happens to the A1c in CKD? See, in CKD, multiple factors affect the A1c. The most important is anemia, erythropoietin treatment, hemodialysis, various other factors lower the A1c, whereas carbamylated hemoglobin, iron deficiency anemia, these can all increase the A1c. So multiple factors at interplay. So while comparing the CGM versus various other alternative markers and A1c, it has been seen that A1c GFR less than 60 ml per minute or more than 64 ml per minute. While comparing the CGM mean glucose, you find that the correlation coefficient is very good actually. It's saying that 0.78 is the A1c with less than 60 and it is 0.72 is the correlation coefficient with this. Even when the GFR are at the multiple levels also, you find that A1c still seems to be one of the important factors. Now, there is one caveat in it. When the UACR is more than 1000 milligram per gram of creatinine, obviously in that condition, A1C is not being found to be very useful. Also, the glycated albumin and fructosamine also, at that urinary albumin creatinine ratio, probably they are not useful. So, Kitogi has told that between G1 to G3B, the A1C is highly reliable. But whereas between G4 and G5, it is less reliable. And in these conditions, probably you need to use an alternate measure. Now, what happens? What happens to A1C in CLD? Now, again in CLD also, it can be inappropriately low, because anemia of chronic illness, blood loss, splenomegaly, aplastic anemia by viral hepatitis, even ribavirin therapy have been shown to be decrease the A1C. So, people have come with a corrected A1C in CLD, that is being given by the formula A1C plus GA by 3, which is the glycated albumin by 3 whole divided by 2. This is, they said that this is independent of liver function, and some of the trials have shown that it is found to be useful, but other studies could not replicate the results. So at present, we can only say that in CLD, probably you need to measure the alternate measures. Now, a study has found that what is the difference between the A1C that is measured, and that has to be calculated A1C from the mean glucose in patients with CLD. So group 1 is less than 0.5 difference, group 2 is 0.5 to 1%, and group 3 is more than 1.5%. And you find that in group 2, nearly 40% of the people have the difference of more than 0.5 to 1 A1C. Group 3, nearly 12% of people have more than 1.5% difference in A1C. That is being measured and that is being predicted. So, in case of CLD, it seems it is not, that is a good marker. Now, this is various drugs. I will not go into details about various drugs that are likely to affect A1C. Now, coming to the last part, the alternate glycemic markers. This includes fructosamine, the glycated albumin, 1,5-N-hydroglucitol, and CGM. I will very briefly tell about it. So, what is fructosamine and how it differs from the glycated albumin? It is the non-enzymatic glycation of amino terminals of proteins, which includes albumin, globulin, and lipoproteins. And it represents mean glucose over the past 2 to 3 weeks, and the rate of glycation seems to be much more than the A1C. It is a suitable alternate to A1C in conditions like hemoglobin traits and CKD, but it will be falsely low where there occurs increased conditions in which there occurs proteinuria, especially nephrotic syndrome, CLD, or various enteropathies. And people have come up with a corrected formula, that is Fa into 4 by albumin, where the albumin levels are getting altered. The main disadvantage is the lack of standardization, unlike A1C. See, A1C is very well standardized, but by NGSP to the DCCT trials. So that's why we are able to compare the A1C results across various studies. But suppose if somebody uses fructosamine and it is not well standardized, so how to compare the results to one from the other? And there are formulas how to predict how to calculate the A1C. Now the other important factor is the glycated albumin, which is nothing but glycation of the serum albumin. It is also same, it represents glycemia over 2 to 3 weeks. It is strongly associated with A1C and FPG, but main advantage is not influenced by abnormal RBC lifespan, unlike A1C, and it will provide more accurate assessment of recent glycemia. Suppose you want glycemia of the past 2 weeks only, it is better to go for a glycated albumin, and it more correlates with the postprandial. Now the 1,5-N-hydroglucitol it is a naturally occurring 6-carbon monosaccharide. It is present in various foods. Normally it gets absorbed from the renal tubules, and it competes with the glucose for its absorption. So any condition in which the urinary glucose increases, the levels of 1,5 Ag will become decreased because the absorption gets decreased. And low serum levels in the presence of hyperglycemia, but normal levels even in hypoglycemia and euglycemia. So the level doesn't alter in hypoglycemia and euglycemia, but it gets reduced in patients with hyperglycemia. That's why some people have used it, and it represents glycemia over a period of 2 to 14 days, and the normal values, it is usually measured in microgram per ml. Now, is there any correlation of various alternative markers with A1C? So this is Eric study, nearly 1700 people. It has gone. So it is a A1C that has been compared, and it has been by comparison of diabetes by A1C or by fasting plasma glucose. You find that the correlations are very good. Now, if you see in diabetes patients, comparing the A1C with 1,5-anhydroglucitol, fructosamine, and glycated albumin, the A1C is very, actually, it is reasonably okay. It is 0.44, 0.58 with fructosamine and glycated albumin, and but it is low with 1,5-anhydroglucitol. So it seems that the glycated albumin and fructosamine, to some extent, they are correlating well with A1C, but not 1,5-anhydroglucitol. Now, can any alternative markers predict the complications like A1C? A1C is able to get predicts many of the complications like nephro or microvascular. Suppose this is a study by EDIC study, and it has shown that while comparing the A1C with glycated albumin with the mean glucose, it has been found that the glycated albumin can also predicting the retinopathy. And it has been found that a 10% increase in the value, it is likely to increase almost 49% compared to the 87% with A1C. So it seems there is some correlation with the retinopathy. Similarly, glycated albumin, while comparing with nephropathy or the microalbuminuria, it is also correlating with the A1C, and it is also able to predict to some extent. But when you compare with the CAD, there is absolutely no correlation. So this again shows that probably we require a long-term trials where looking at the lot of data, then only we can come to this conclusion. At present, only the A1C is the only one which actually predicts the various complications, both micro and macrovascular complications. Now the last part is the CGM. CGM glucose monitoring, we all know that we are doing it every day. It monitors the interstitial glucose 1 to 5 minutes. It is indicated for patients with both type 1 and type 2 with multiple injections. Various methods are there. The main advantages are the real-time glucose values, which are unlikely to get by the other methods. Glycemic variability we will know, and it is useful in pregnancy and CKD. And while comparing the CGM with A1C, glycated albumin, fructosamine, and 1,5-AG, it has been seen that A1C is correlating very well with glycated albumin, fructosamine, but not with 1,5-AG. So, meaning by that, 1,5-AG is a less correlating with the A1C compared to the many of the other markers. So, my final slide, the take-home message is A1C is the integrated glycemic measure over the past 2 to 3 months. It generally works well, but should be cautious in conditions like hemoglobin variants, CKD, CLD, and disorders of erythropoiesis survival. GA-FA are good alternatives if there is a mismatch between the measured glucose values and A1C, but less effective in proteinuria or albuminuric conditions. 1,5-AG is generally less correlated with other markers. More studies are needed if alternate markers can predict long-term complications like A1C. I thank you all for your kind listening.
Thank you, sir.
Thank you.
Thank you, sir, for your wonderful speech. The next presentation is Adiposopathy, and it will be done by Dr. Sandeep Mathur, Professor and Head of the Department of Endocrinology and in charge of Molecular Genetic Research Lab, SMS Medical College, Jaipur. Over to you, sir.
Okay, thank you very much. And actually, I am introducing the concept of adiposopathy as a disease. It is still a concept, and we need to work very hard. It is very specific to our population, and we need to establish at clinical front, it should be a diagnostic entity. The idea is that we South Asians have a relative lower BMI, high insulin resistance, other high prevalence of clustering disease. It is associated with a pathology in adipose tissue, like your tuberculosis symptom, you have a caseating granuloma. There is adipocyte hypertrophy as well as M1, M2 altered polarity inflammation. It has a pathophysiology, and it is clustered with disease, but this cluster disease metabolic syndrome could never come to prescription. But my presentation here focus and suggest one point, can we bring adiposopathy as a diagnostic entity? I will tell you why it is important. So what is pathological adipose tissue? When adipose tissue respond to calorie excess or sedentary lifestyle, there are two patterns. One is there is adipocyte hyperplasia. It is not associated with much of cellular stress, good angiogenesis. In extreme state, there is inflammation. But other hand, there are people who have poor adipogenesis. This will lead to adipocyte hypertrophy, cell stress, inflammation, particularly M1 more than M2 macrophage infiltration. This leads to altered adipocytokinemia, altered inflammatory marker, and fatty acid reflux. This leads to dysfunction of other organs like your pancreatic beta cell, blood vessels, liver, and muscle, lead to insulin resistance, all metabolic syndrome component. This pathology and pathophysiology can be reflected on imaging in three patterns of body fat compartmentalization. There is a lipodystrophy syndrome. There is no subcutaneous fat, no adipogenesis, no fat storage in the subcutaneous fat, ectopic fat, and severe metabolic disorder. On the other hand, are at the extreme end, individual very good adipogenesis, lot of adipocyte hyperplasia, adipocyte proliferation. Person is able to hold all this fat in his subcutaneous compartment predominantly, and there is no metabolic, dysmetabolic, or vascular disease. But in between, there is a group of people, which are the majority people we see on practice of diabetic and metabolic syndrome, where adipogenesis limitation is there, leading to adipocyte hypertrophy, leading to ectopic fat inflammation and all metabolic consequences. So what is the concept of adiposopathy? So this pathology of adipose tissue, which is in between the spectrum of adipocyte size and dysmetabolic relationship, the experts believe, some group believe, this can be a primary disease. Because you treat the primary disease. We used to do tuberculosis with couching long back, with diabetes with some other thing, BP with other thing, but we never treat the root cause. So they say, at least at concept layer, we should accept as a disease, and they describe its etiology, genetic factor, very important, lifestyle factor. Its pathologic marker is adipocyte hypertrophy and inflammatory macrophage infiltration with M1 shift in polarity. It has a pathophysiology, altered adipocytokinemia, like decreased leptin, increased fatty acid and all. It has so many clinical manifestations, right from diabetes, hypertension, dyslipidemia, atherosclerosis, fatty liver, PCOD, and so on. And these problems can be because of some other region also. Doesn't mean every patient suffering these diseases are suffering from adiposopathy. Adipose itself is gain entity. This is what they have recommended. So what is South Asian phenotype? We are having lower BMI, and we are at high risk of all insulin resistant and complication. And we believe it is because of excess visceral fat. Everybody take visceral fat, visceral fat, visceral fat. But you see, if you surgically remove the omentum, there is no advantage. Otherwise, this surgery could have been done 50 years, developed 50 years ago. What excess visceral fat alone can't explain high insulin resistance and vascular matter risk in our population. So the challenging question is, does South Asian T2DM metabolic syndrome phenotype, thin fat, represent adiposopathy? Adipose tissue pathology. So what are the evidences? So I am presenting here 5 types of evidences. Body fat distribution in T2 and MET individual and its relationship with insulin resistance. And what we find, we actually did MRI of the diabetics and the control, diabetics, metabolic syndrome and controls. And when we look for fat distribution, what we find, it was the ectopic fat in liver instead of intraperitoneal fat around the vital organs. That shows strong correlation with your insulin resistance. So it's an ectopic fat in liver, not the fat in your viscera, around your viscera. Number 2, first time in world we study this correlation in degree of insulin resistance. As degree of insulin resistance goes up, role of ectopic fat increase, but role of subcutaneous fat decrease. Subcutaneous fats show negative correlation, highest quartile. That means your metabolic vascular disease because of ectopic fat rather than fat around vital organ, and a subcutaneous abdominal fat may be rather protective. So even in Indians, we have, most landmark study, they say they have more visceral abdominal fat, but they also have less peripheral fat, which is not much talked about, very important. So evidence number 2, is T2DM and metastasis South Asian is associated with pathology change in adipose tissue? What are the light microscopic evidences? Because as you take the blood, you can biopsy fat also. Because I am coming with the concept peripheral fat is one of the most important. So taking biopsy will be as simple as you're taking blood sample. So let us come to the concept of Indian phenotype, because when they compare South Asian with Caucasian, Indians have a different phenotype. But what then when they look for adipocyte size, South Asian compared to Caucasian have higher waist to ratio, fasting insulin, lower HDL cholesterol, lower adiponectin, but they have more liver fat and adipocyte area. So this problem of adipocyte hypertrophy and ectopic fat is more specific to our population. Why Western people doesn't talk of adiposopathy much? Because it is simply related to BMI or overall weight. Our it is related to ectopic fat and your adipocyte hypertrophy. Secondly, after adjustment for adipocyte area, there was no ethnical difference. Suppose let us compare South Asian with Caucasian. South Asian less fat, Caucasian more fat, less disease, and everything was less. Lipid was better, everything was better for same BMI. But we corrected for adipocyte size, there was no difference. So racial difference between South Asian and Caucasian only because of adipocyte hypertrophy. In another study, which is from Glasgow, weight gain in South Asian was associated with more actually liver fat deposition. They had already high fat deposition. And weight gain then was associated with 38% decline in insulin sensitivity as compared to only 7% in Caucasians. And there was a 160% increase in HOMA-IR as compared to 4% Western Caucasians, Western population. That means weight gain is very detrimental for our population. And that is as compared to Caucasians. So that is the point, very important point. And lastly, most important, there was a larger adipocyte size in South Asians. But very important point, whenever there was a weight gain, there was a adipogenesis in Caucasians. A small adipocytes increase in number. In South Asian, there was no increase in number of adipocyte size because they were already full size and lead to ectopic fat deposition. So these two point, adiposopathy is primarily our problem, and we are the big country, 140 population, and we are just saying Western say this, Western say that. Now we further look into this point. This is our latest paper, just accepted in frontier endocrinology from my group. We compare 3 aspects of adipose tissue: fat distribution, fat quantity, as well as adiposopathy in terms of adipocyte size and number of macrophage cells. So we find diabetics as compared to non-diabetics. Diabetics has all parameters high. They had more visceral fat quantity by MRI. They had more peripheral fat. They had all these biochemical parameters were high in diabetics. I will not go into that. But femoral adipocyte size as well as visceral adipocyte size, I am coming with the concept which actually my paper rejected by JCM. Okay, you are telling in the well-established question, we will not accept it. I don't want to submit any paper to all these papers, journals, for that reason. Then you saw it was larger. Peripheral adipocyte was larger. Visceral adipocyte was larger. They were trained toward larger subcutaneous adipocyte size. And M1, M2 macrophage was also trained toward larger, higher in diabetes as compared to non-diabetics. And what I find, there was excess liver fat, and the excess liver fat remained even when we corrected for BMI. That means development of diabetes is excess liver fat irrespective of your BMI. That is the major player of our pathophysiology. And when I corrected adipose depots volume, which was measured by DEXA and as well as MRI, when corrected for adipocyte, there was no difference. That means if a diabetic or metabolic syndrome has more visceral or peripheral fat, it reflects adipocyte hypertrophy. That means qualitative defect of the adipose tissue, which is reflected into quantitative trait. And lastly, more important, all adipose compartments showed correlation with your insulin resistance. But when I corrected for adipocyte size, there was no association. That means whatever the role of adipose compartment, let it be visceral, let it be peripheral, it is because of adipocyte hypertrophy. It is not of the large quantity of the fat in these compartments. So this is an important finding. So we say what distinguishes a diabetic from equal weight non-diabetic, it is adipocyte hypertrophy. This is the major difference. Adiposopathy differentiate them. And this paper will be very soon will be actually published. It is only accepted for publication. Now, what is T2 medicine? So, we pathology changing at molecular level Actually, we were funded by ICMR and we published a lot of paper a couple of years ago. What we did with transcription profiling of adipose tissue compartment, visceral, subcutaneous, peripheral, and we looked for gene expression pattern and tried to infer the molecular function. And what we find, all these studies, I will not go in detail, that diabetes and metabolic syndrome was associated with altered expression of certain gene and co-expressed gene. Their modules show correlation with diabetes intermediate phenotypic traits, and they enrich the pathway of adipogenesis and inflammation. So at molecular level, we have demonstrated that there is a adiposopathy in diabetic patient. Now, so this I already spoken. Now evidence number 4, does T2-IR share a common molecular mechanism with lipodystrophy syndrome? You know, lipodystrophy syndrome is a rare disease. It is an experiment of nature. There is a mutation in certain genes which are involved in adipose tissue, adipogenesis or adipose tissue handling of the fat. If there is severe dysfunction because of severe mutation, lethal mutation, no adipose tissue or adipose tissue function, ectopic fat and severe metabolic syndrome. I came with a hypothesis, this is my original idea, that metabolic syndrome reflects functional defect of lipodystrophy genes. That means gene expression is less, it will lead to metabolic syndrome. If gene is mutated, it will lead to lipodystrophy syndrome. Then that means they share a common pathophysiologic pathways. And these are two papers published. Then we have a recent paper in Frontiers in Endocrinology again. What we have demonstrated, all those genes which have favorable effect on handling of fat by adipose tissue, they are down-regulated in diabetics and metabolic syndrome, and those who have other way around effect, major they were up-regulated. Means the genes which are known for handling are altered expression in adipose tissue in our diabetic patients. So this is the one of the major pathophysiologic mechanism of diabetes and metabolic syndrome. And this slide is very important because ultimately we are looking for personalized therapy, and on the basis of expression only 50 genes in adipose tissue, 23,000 genes, 50 lipodystrophy gene, their expression, permutation, combination using machine learning model, we could say we can differentiate a patient who has metabolic syndrome, who is a mild metabolic syndrome, 1 disease, 2 disease, 4 disease. So severity of metabolic syndrome can be predicted in this machine learning model on the basis of only 50 lipodystrophy gene. Because complex genetic expert I realize, because 23 down, their permutation, combination, so many variants, it's very complex. So it narrowed down to only 50 genes. You can predict, let me take your biopsy, let me study expression of your 50 genes, like we do qPCR in your COVID, and on the basis that I can predict your metabolic syndrome or not. So it is so dynamic, actually forceful mechanism of your diabetes and metabolic syndrome pathophysiology. And lastly, does genetic susceptibility T2 MET syndrome express in adipose tissue? Because so genetically complex, I'm more a geneticist than a clinical endocrinologist, though I have both the background. So I see these diseases as a genetic disease because they are the drivers of all pathophysiology. They conspire with the environment. We have done JIVAs and identified genetic loci which show association diabetes and metabolic syndrome. And I've taken this from the actually British studies. They develop risk score on the basis of genes or genetic loci association with diabetes and metabolic syndrome. And interestingly, they have shown insulin resistance score was associated with lower BMI. You understand? 2 persons together who is genetically susceptible, he will develop diabetes at a lower BMI. That means genetic susceptibility acts through less fat, that is adipogenesis failure, though they have not done functional studies. Similarly, they had 53 genomic region risk score. Again, it was associated with lower adipose tissue mass in peripheral compartments. So less fat in periphery is the real culprit. And adiposopathy in other compartment is the culprit. It is not visceral fat in the abdomen. And this study, which came from Sarah Finer's group, a very eye-opener to me. But most people will understand this interpretation. Even the authors have not done that. That partial polygenic risk score for diabetes and intermediate phenotypic traits. In Indians, there were only 2 scores were important. One was beta 2, otherwise lipodystrophy. That means genetic susceptibility leads to abnormal fat distribution. Could be possibly because of poor evolution. I am coming to that point. it lead to, it drives the whole story. So if you want to really cure diabetes, treat it at a very root level, we have to drugs to be developed in this direction, rather than we go for GLP and all those things. Though they are important, I'm not saying, but they are the right culprit root causes. So to shed light on genome to phenome pathway, we had a paper published in 2011. We at that time used gene network and machine learning model, even that time we used. And we find all the diabetes associated genes are expressed in their network in adipose tissue. People believe diabetes genes express only in pancreas and genetic component only lead to beta cell failure. It was also 14 years ago we came with the concept, no, they are expressed in adipose tissue also in their network. In fact, one of the lady from American Institute of Science quoted this paper as one of the top 5 research paper from India in 2011, because this was a new concept. Now we had one paper published in Scientific Reports where a crystal clear shown the gene expression abnormality are regulated by certain kinases, microRNAs, proteins, and they all are mapped, they are associated with diabetes related phenotypic traits, and they are all mapped to GWA identify loci. The first time an attempt was made to decipher genome to phenome pathway, and with only 6 patient data, Nature group published in Scientific Record, because it is so robust, so eye-opener, they publish even without change in the dot or in the word, single word. Similarly, we use machine learning model to predict. We actually identify metagenome, the gene expression profile, which is associated with insulin resistance, and we tested in a group of diabetics gene expression profile, and one can predict diabetic with 73% accuracy. This is very eye-opener, because if you have adipose tissue pathology, it's gene expression signatures, molecular signatures, you take to unclassified person and see, can it predict someone is diabetic, non-diabetic? It is with 73% accuracy. So story of beta cell possibly drives from your adipose tissue. And another paper we looked, this is upper paper, we look for genes showing associated with diabetes and intermediate phenotypic trait. When we put them in silico, they enrich adipocentric pathway. So I am coming with the concept, the major pathophysiological driver is your adiposopathy. So as a conclusion, I am presenting here a model of disease. You know, metabolic syndrome means there is a common soil, we don't talk about that. I say this common soil from which everything comes out is adiposopathy or sick fat. And you know, as an agriculturist, I know if I do something good on soil, always the crop is better. And metabolic syndrome constitutes only cluster of disease, and based on my own findings, because I am the only one who is working in this direction in this so far, but I want more people to join us. There is a genetic susceptibility to abnormal fat distribution, genetic susceptibility to adipogenesis failure. It is it's regulatory molecules, they are mapped to genetic susceptibility, they lead to abnormal cell expression pattern, lead to adipose tissue hypertrophy, inflammation and everything, and lead to end organ damage. So this is a model of disease which we are predicting, and lot of work is to be done to establish adiposopathy as a clinical diagnostic entity. I asked this resident to take biopsies from patients coming with diabetes, IGT and controls, and see how their adipose tissue biology differs. Thank you very much for the patience hearing.
Thank you, sir. Next, I think Usha, madam.
Okay, sir. Thank you, sir, for a nice session and simplifying manner. And adiposopathy is a nice topic and to learn it. Thank you, sir. Thank you. Sir, we'll take some questions and comments if possible. You can take some questions.
Hello, Usha madam is not here. Okay, so we'll just play a video. She's shared actually related to the topic. Okay, the video will last for 20 minutes. 20 minutes. Okay, and followed by this we will have the discussion section.
any thalassemia patient. Why? Because if you do not do CBC, you cannot measure Menger's index.
From Chennai.
MCB divided by total RBC. Very easy. If it is less than 14, the chance, there is 90% chance that patient is having thalassemia. You go for HPLC, and if you invariably will get beta thalassemia trait, if you do not get, think of alpha thalassemia, which has to be diagnosed only by genetic studies. Number one.
Excuse
Number
me, sir.
two.
Sir, we can have the question after followed by the video. Okay.
Good morning, everyone. This is Usha Sriram from Chennai. I am going to give a talk on preconception care as a strategy for long-term metabolic health. Apologies for not being there in person, recovering from a respiratory infection. And what I will be doing is go over the what, why, when, where, who, how of preconception care and future metabolic health for women. The aim of preconception care is the provision of biomedical, behavioral, and social health interventions to women and couples before conception occurs. And the aim is to improve the health status and reducing behaviors, individual and environmental factors that could contribute to poor maternal and child health outcomes. But of course, its ultimate aim is improved in maternal child health outcomes, both in the short and the long term, and the long term is something that we are concerned about today. I would like to draw your attention to this editorial Lancet from 2018. It says campaigning for preconception health. A campaign for preconception health therefore needs to be a clever, three-pronged approach, taking the different preconception phases and definitions into account. For a start, there should be no obesity strategy, no undernutrition strategy, no non-communicable disease strategy, no adolescent health strategy without including preconception. This is what the editorial said, and that's really what I am also trying to emphasize. And in this paper on gestational diabetes, again you can see current challenges and research gaps. One of the biggest things is preconception care. With preconception care, probably we are looking at prevention of gestational diabetes, and also if the woman has had children, and this has to be offered in her next pregnancy, so we can avoid GDM during the next pregnancy, and also probably lower her chances of cardiometabolic disorders later in life. So why the need for preconception care? Most pregnancies are unplanned. Women now enter the pregnancy older, heavier, more nutritional deficiencies, metabolic problems, exposed to environmental pollution, unhealthy behaviors like smoking, alcohol, and recreational drug use maybe, and greater mental stress. And we all know that the first 8 weeks are critical for organogenesis, and the window starts closing before the antenatal visit. Just to show you how unintended pregnancies, especially in low-income countries, are significantly high, also leading to higher abortion rates. I mean, we are not talking just about intended and unintended pregnancies. Even in the intended pregnancies, they are not planned as the way we want them to be planned, entering the pregnancies in a healthier state. And if you see that women are entering pregnancy with more health issues, in this study they looked at chronic non-communicable disease burden among reproductive age women in India, if you see here, the presence of multi-morbidities and single morbidities so significantly high. We're talking about relatively young women. The women of reproductive age are 15 to 49, and to have this high a prevalence of multi-morbidities is quite alarming. In this study, looked at pre-diabetes and diabetes. You can see that pre-diabetes is particularly high in young women, as high as 30 to 40%, and this will translate to gestational diabetes or other pregnancy complications, and this is across sorry, Chennai, Delhi, and Karachi. And interventions that after the start of a pregnancy have not yielded the required results. So it's too late, the window is closed, the horse is out of the barn. The developmental origin of adult disease has its origins in maternal health, nutrition, chronic diseases, infection, smoking, mental health. Pregnancy is a window to future chronic disease. Optimizing maternal health before pregnancy could decrease high-risk pregnancies and low birth weight. So just to show you the evidence for that, that any intervention that starts after the pregnancy is really not that impactful. And when we talk about the Barker hypothesis, the developmental origin of health and disease hypothesis, we know that many things, exposure during prenatal and early postnatal, influence lifelong built-in capacity to permanent effects on metabolism, structure, and growth, what we call programming. We know about birth weight and risk of diabetes, but I also want to show that if the mother's birth weight is low, we've also shown increased risk of gestational diabetes. So it becomes a vicious cycle. Now, about this pregnancy as a window to future chronic disease, that's really the most important message that I want to convey here, that if a woman has a complicated pregnancy, gestational diabetes, gestational hypertension, low birth weight baby, preterm delivery, miscarriages, any of these things, she's at greater risk for future chronic disease. And these conditions are also addictive. So if she has hypertensive disorder of pregnancy and a low birth weight baby, her risk of future cardiovascular disease is higher. So as you can see, the risk factors for gestational diabetes are many, and therefore, if we are able to identify any of the modifiable risk factors during the preconception period, we could address it and lower the risk of future gestational diabetes. And we also know that gestational diabetes increases the risk of future type 2 diabetes as high as 10 to 11-fold if it happens in the first pregnancy, and even higher if it happens in the second and subsequent pregnancies. And if the BMI is higher, the risk keeps going up and also persists many years into life. But another really critical fact that I want to point out is that if a woman has any of these complications, she's at greater risk for future cardiometabolic disease. The risk of NCDs go up exponentially if she has any of these pregnancy risks, which can all be addressed if she had good preconception care. So, and we also are really concerned about the diabetes crisis that is happening, and women are very, though they have equal numbers of diabetes compared to men, their mortality is higher, more adverse outcomes, and of course the life cycle of women predisposes them to many other complications. So there are millions of women of reproductive age, billions of women actually, reproductive age worldwide. India alone, there's about 24 to 25 million births per year, and anywhere from 15 to 20% risk of gestational diabetes. However, we do not have, there's a lack of equitable and affordable maternal health, as I have talked about the unplanned pregnancies and high-risk pregnancies, and the healthcare system challenges are many: limited time, consultation time, resources, training, health policies, and practice patterns. And moving to another serious issue that women face, especially in the reproductive years, is obesity. And the percentage has gone up significantly. The most recent NFHS5 tells us that 24% of women of reproductive age are obese. And what does obesity do during pregnancy? Everything goes up: hypertensive disorders, preeclampsia, gestational diabetes. Just want to show you another graphic form. Compared to women who are non-obese, if a woman is obese, her risk of gestational diabetes is very high, in addition to other complications that she has, including operative deliveries and hypertensive disorders. And a very important new data that I want to show, hot off the press, shows that this is from the HAPO study analysis, the association between maternal pre-pregnancy adiposity and midlife cardiovascular disease risk factors and mediation of gestational diabetes and new onset hypertensive disorders in pregnancy. So, pre-pregnancy body mass index and adverse pregnancy outcomes, and then future midlife cardiovascular disease risk, which of course is a composite of metabolic issues that women have, lipid disorders, elevated glucose, and blood pressure, much higher in women who are overweight prior to the pregnancy. And as women get older, we also know during menopause transition, due to hormonal changes, there's a greater risk of cardiometabolic risk. All of this has prompted the professional organizations, and I just want to show one, FIGO, International Federation of Gynecology and Obstetrics. So they have put out a position statement: prevention of non-communicable diseases by interventions in the preconception period. This is a very, very critical paper. And so we'll discuss some more about the, now more about the when, where, and what of the preconception care. So this is from the FIGO paper. They say that preconception care can and should be delivered in any clinical or hospital setting, regardless of the initial reason for a hospital visit, and either in inpatient or outpatient therapy. Hospital-based and community-based opportunistic preconception care is recommended. This includes visits for contraception, immunization, child health services, any touch point where a woman of reproductive age comes to the healthcare system. And so a universal approach of discussing good nutritional habits, risks of obesity, possible benefits of weight loss before pregnancy, and every visit to a healthcare practitioner is recommended. And I'm a big fan of this slide, which shows how, from the International Journal of Cardiology, when do they start talking to girls with congenital heart disease about preconception care? Okay. So if you look here, teenagers with congenital heart disease, timely counseling on contraception and pregnancy risks by the pediatric physician. Don't wait for adulthood on sexual activity, may precede this. It not only protects this girl's heart, also prevents other complications in the future. And then they're talking like women with congenital heart disease perform pre-pregnancy counseling, provide multidisciplinary preconceptional advice, fertility issues, just as she gets a little older. And we're not going to wait for her to show up in the OBGYN's office pregnant. And another important time that we miss is the postpartum period. Postpartum is actually preconception time for the next pregnancy. So in addition to all other benefits, if we pay attention to the postpartum health of women, they are likely to enter the next pregnancy in a healthier state. I'll tell you the reason for that. One of them is gestational weight gain. Some of it gets reclaimed. Therefore, in the second pregnancy, they already have a higher preconception BMI if this has not been addressed. Now there is more weight gain, increased fat mass, increased visceral fat, greater risk for gestational diabetes, preeclampsia. So we see how important the postpartum period is. And also want to say that even women who have pre-existing conditions do not seek or are not offered and do not seek preconception care. In this audit from the UK, you can see how women have, very few of them have been, undergone proper preparation for a pregnancy. And this is people who already have diabetes. And you can imagine those who have pre-diabetes or have other conditions that they don't take seriously. And even the A1Cs very suboptimally controlled. Now, moving on to what really we are looking at in terms of preconception care, screening and management from a metabolic point of view, screening and management of pre-diabetes, metabolic syndrome in women of reproductive age through this preconception care, screening and management of obesity in women of reproductive age. Two big challenges, two great windows of opportunity. In addition, we are addressing PCOS, thyroid dysfunction, environmental factors, and other drivers of diabetes through the preconception care. Now, this again from the FIGO position paper and the Lancet paper, I want to show you. So when do we do this? I already showed the opportunistic screening. But in addition, we need to know how long before the pregnancy we need to put in these preconception strategies. For example, if you want to start folic acid, it can be started a month or two before they plan their pregnancy, maybe 3 months. But if we are talking about stopping smoking, it may take a little longer. But if we're talking about optimizing their weight, that may take even longer. Making sure that they change their eating habits and get onto a healthy eating pattern, being physically active, that might take longer. And mental stress, again, very important component of preconception care. Counseling people about mental stress, that may take some time. So as you can see, it can be anything from 3 months or under to 3 or more years, depending upon what we are trying to achieve. In terms of what are the components of preconception care, just want to tell you, we have created a very simple A to Z, which shows us A from anemia to blood pressure to contraception, diabetes, the environment, folic acid, genetic history, health history, immunization, what kind of job, and one key question, which is what is their reproductive plan, their lifestyle, mental health, non-communicable diseases pre-existing, obstetric obstetric history, partner health where applicable, quitting smoking and alcohol, prescription drugs that they are taking, social determinants of health, especially built environment, finances, education, thyroid disorders, unsafe sexual practice, violence, intimate partner violence, verbal abuse, weight, which we have talked about, physical activity, and the very young. They need very special attention. And in countries in South Asia, still a lot of very young girls are getting married and having babies. And in many countries, we know that there can be very young girls who get pregnant. And of course, sleep is a very important thing. So going through this checklist can be very, very critical and crucial for the young girls. So we come to the end of the program, and we, to help in this regard, have come up with an app called Be Ready, which we will be launching soon, which is primarily for preconception care and putting girls and women on a healthy trajectory for life. And the 3D project, which Dhira and the George Institute have put together, again is working.
Thank you, ma'am.
Okay, so the hall is open for discussion now.
Yeah.
Yes, sir. What I was telling that we must do CBC, not hemoglobin TCDC, sir, because if you can diagnose Menger's index just with MCV divided by total RBC less than 14, then that is good enough. You go for an HPLC, in 90% case we get beta cell trait, and 10% alpha thalassemia we miss it, because for that you have to do genetic study. Why I am telling, in my practice I have seen that when I used to do hemoglobin TCDC, many patients, and now I am doing CBC, so some male patients, out of my surprise, with hemoglobin 13, we have found that patient is having beta thalassemia carrier, and which will never thought. And if I find that is having thalassemia trait by doing Menger's index, probably I will not rely on HbIc. So that is the message, to go for CBC, not hemoglobin, and please calculate Menger's index. Very easy, MCV divided by total RBC. If it is less than 14, please go for HPLC. Thank you, sir.
Sir, your point is very well taken. Actually, the Menger's index distinguishes or differentiates between iron deficiency anemia from thalassemia trait, because both of them the appearance is almost similar. But as you rightly pointed out, yes, we need to do the CBC to find out if we are seeing that if there is a Menger's index is more than 13 or 14 or less than 14, accordingly you can do it. The only thing is that in thalassemias, in alpha or beta thalassemias, in either case, because it is a major one, it is a hemolytic state. So in that conditions, we cannot go for HPLC based upon A1C methods. But in trait conditions where you can able to distinguish, if the trait comes and you have got certain problems, then you have to go for the alternate methods like GA, FA, and all those things, what we were discussing earlier.
If there are any more questions, I would like to share one of my experience with beta thalassemia trait. Actually, one patient, we had some 35 years lady, sugars with the metformin 500 BD have well controlled, fasting 90-95, PPUS less than 140, HbA1c is 14. So we have done a CGM at that time, at the initial time. CGM was showing normal sugars. So we have been keeping her with metformin, and in between, just for the sake of checking, we have checked the HbA1c always about 10. So what happened was that recently she wanted to get her CABG done. She had gone there with an FBS, PPUS, and HbA1c. Fasting PPUS normal, HbA1c 14. And this CTVS, they said they wanted to keep her on insulin prior to that, make her HbA1c less than 7.5. And I have written to that, this sugars, because of this, her sugars are normal, and this HbA1c is not a contraindication for surgery. Still, they wanted a proof for that. So we had two choices, either a CGMS. CGMS will cost around 4,000. Other than that, we did a fructosamine recently. So it is not that costly, around less than 1,000 only. And the problem is that it is not well standardized. That 200 to 280 that they say is in the normal euglycemic range. So how we will interpret a 320 or 300, that's a problem. But that patient, it was some around 200, and we said it is normoglycemia, and you can take her for surgery. That was a recent incident we came across.
Actually, the similar instances of the case you have described, similar incidences we have seen so many. Actually, many times it so happens that one of our patients had always in the glycemic range was always in the normal range, but always A1C is more than 15. So that patient has actually gone to multiple doctors, and everybody was perplexed what to do next. And instead of doing CGM, we have directly gone the fructosamine, and fructosamine has come down to be perfectly within the normal range. So where there are many conditions in which there can be two important things. One, there can be alteration in the A1C due to interference in the system. For example, HbA1c or something else, there can be interference, or there can be traits which we sometimes is not able to get detected by the HbA1c machine. So in those conditions, again, HbA1c is also, there are different methods. Different companies have got certain different things. The one which we are mostly using is the BioRed system. There are also TOSO, there are also other companies, but where you find that all are not same. All the HbA1c is by the same principle everybody employs, but all are not same. So some gets interference, so others are not getting interference. So the best thing for your case and similar cases, I think we need to go for the alternate markers. That is very good idea.
Sir, there are some other indices like glycemic gap and HGA also. How they can interpret those?
See, glycation gap, that is the gap between the A1C that is we are measuring and the A1C that is being predicted. So that is the gap. So the predicted A1C can be predicted from the various formulas, either based upon a fructosamine or from a glycated albumin. The thing is that the meaning of a glycation gap is, suppose for a similar glycemic level, somebody can have a increased A1C, somebody can have a decreased A1C. So there is a genetic propensity for this glycation, which is not only dependent upon the glycemia, but also other factors. So suppose somebody comes with a glycation gaps is more. That means for a given glycemia in the blood, the A1C levels are high because of factors like glycation, etc.
Thank you, sir, for nice session. We can close this session here, and thank you, team.
Thank you, everyone, for patiently listening to us. We have the valedictory and our ceremony from 1:45 p.m. in the hall A. Those who want to join there can go. Otherwise, we have to conclude this session. Hope we can meet for the next year in ASICON 2026 in Chennai. Well, we look forward to meet everyone there. Thank you.